berjalan.
Okay.
We will open the session started from 9 a.m. and our audiences will be all urologists and also residents urologists and also pathologists anatomists may join in to the session. Okay, it's already 9 a.m. and I will try to open the session. Okay. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi. Salam sehat untuk kita semua. Good morning, everyone. Thank you for attending into this session. Thank you, Prof, doctors for signing into this session. This is our continuous medical education collaboration between PT Johnson & Johnson Indonesia and PPIAWI, Indonesian Association Urology, with Prostate Cancer Masterclass 2023 from Indonesia. Today, in Saturday, 5th August 2023, we would like to open and allow me to introduce myself. My name is Linggarati Ayu and I'm from Johnson & Johnson Indonesia too. First of all, we would like to send my gratitude to all the speakers and all attendees or participants today. Before we start the session, we would like to inform you that this session will be recorded by our committee. Then after you put your name and your information into the registration, it means you already accept that this webinar and your privacy will be recorded. Then this session is sponsored by PT Johnson & Johnson Indonesia too. And we would like to inform you again that this is not intended for promotion or influence any product. This is purely for healthcare professional, whereas the objective to sharing, discuss your ideas, experiences, for increased awareness and also provide recent update and knowledge of advanced prostate cancer management strategies. If in the session may contain information or any products or any indications that under investigation and or that have not been approved yet by the regulatory authority, please kindly refer to our local approval in Indonesia. Housekeeping for today. Firstly, we would like to you to mute for a while during the presentation. And also after that, after the session, we will take about 30 minutes discussion session, and you may share your thoughts and also you may type your question into the chat box below. And also we have a pre and post event survey. I will put the pre-event survey on the link chat after this, and post-event survey after the session. This is very necessary to as a part of requirement for certificate, for ED certificate. And the last, before we close the session, please turn on your camera to take some photos together. This is the link for pre-survey, but I will put on the chat box. Okay, the agenda today, agenda highlight for today. We would like to have a very good topics and very good speakers for today. And first of all, before we start the session, we will share some topics for today. Our event chairman today is Dr. Ferry Sapriyadi, specialist urologist, FHS from SPN Dr. Hasan Sadikin Bandung, that will start the session with the topic Treatment Across the Prostate Cancer Continuum, Precision Medicine Revolution. Then we will have the first speaker, Dr. Didik Setio Herianto, a PhD Specialist Pathology Anatomist from Faculty of Medicine, Universitas Gadjah Mada, Yogyakarta, that will bring the very great topic about pathologist perspective, basic concept of BRCA mutation. The second topic is a very great topic also from Associate Prof. Edmund Cheong from Department of Surgery, Yong Lo Lin School of Medicine, National University of Singapore, about urologist perspective, current practice in genetic BRCA testing in MCRPC. Last but not that least, we have the third speaker, Dr. Fauriski Febrian Prapiska, Specialist Urologist Consultant from Adam Malik General Hospital, Medan, that will bring the very great topic also about urologist perspective, PARP inhibitor as the precision therapeutics targeting in MCRPC. Then our event chairman, Dr. Ferry, will bring us together to discuss and share your thoughts, your advice maybe for this session. Okay, before we start the session, we will have great opening remarks from Prof. Dr. Ponco Birowo, Specialist Urology Consultant PhD, as a Vice Chairman of Indonesian Urological Association or IAUI. Prof. Ponco, the time is yours.
Yeah, thank you very much, Dr. Linggarati Hayu. Good morning, everybody. Assalamualaikum warahmatullahi wabarakatuh. This morning, I am on behalf of Dr. Busudaryanto as the chairman of, or as a president of Indonesian Urology Association. I would like to thank Professor Edmund Cheong, Dr. Didik Setio Herianto, Dr. Fauriski Febrian Prapiska, and my senior, Dr. Ferry Safriadi, who already commit their time to share the knowledge to Indonesian urologists. It is our commitment, Indonesian Urology Association, as an organization to support the member of Indonesian Urology Association to continuously improve the knowledge about the recent knowledge about urology in this field is about the prostate cancer. Yeah, it is our duty to increase the knowledge of our urologists in order to get a benefit at the end, the benefit for the patient, so we can increase our service to our patients, and at the end, the patient will receive the best treatment of their condition in urology cases, especially in the prostate cancer. I would like to thank also to JNG for the generosity to help this webinar. So at the end, I would like to congratulate to everybody, and please enjoy the nice webinar. Thank you very much.
Thank you, Prof. Ponco, for your opening remarks. Very insightful for us. Then we will continue to Dr. Rospita Dian as our Head of Medical Affairs, PT Johnson & Johnson Indonesia 2. Time is yours, Dr. Dian. Halo, Dr. Dian.
Okay, terima kasih. I cannot unmute myself previously.
Yeah. Please, Dr. Dian.
Okay. Thank you, Dr. Linggar. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera bagi kita semua. The Honorable Prof. Ponco Birowo, as IAUI Vice Chairman, as representative from IAUI. Our distinguished faculties, our moderator, Dr. Ferry Safriadi, our speakers, Dr. Didik Setio Herianto, Dr. Fauriski Febrian Prapiska, and our guest speaker, Prof. Edmund Cheong from Singapore. And last but not least, our distinguished participants, professors and doctors. Good morning. It's an honor for me to welcome you all on behalf of Johnson & Johnson Indonesia in today's event, 2023 Prostate Cancer Masterclass. First of all, allow me to share our gratitude to God Almighty for granting health and opportunity for all of us to be able to gather this morning. I would like to thank ELE for continuous collaboration and support during last several years in organizing series of signature medical education events, which are PCAS, Prostate Cancer Scientific Discussion, and also Prostate Cancer Masterclass, the event that we had today. I would like to thank all faculties, moderators, and speakers for accepting our invitations to share their knowledge and experience in prostate cancer management. As we are all aware, precision medicine has become more and more established in oncology field, including prostate cancer management. And today, we will focus on the diagnostic testing of BRCA mutations and the role of PARP inhibitor as the precision therapeutics targeting in mCRPC. We hope today's sessions will be beneficial for all of us in elevating our knowledge and also perspective and reaching our perspectives in prostate cancer management. And in the end, it will be beneficial for prostate cancer patients in Indonesia. Again, thank you all for your attention and wish all of us has a smooth and successful event. Back to you again, MC, Dr. Linggar.
Thank you, Dr. Dian, for your insightful also for us today. So, okay, because of time is still running, we would like to give the time to Dr. Ferry Safriadi, specialist urologist at PCS, to open this session as an event chairman. That firstly, I would like to share you the CV, the short, brief CV of Dr. Ferry. Dr. Ferry has graduated from medical degree of Faculty Medicine Pajajaran University and also urology training program University of Indonesia in 2002, fellow on invasive bladder cancer and urinary diversion in Mansoura, Egypt, 2009, fellow of advanced laparoscopic urological surgery, Taichung, Taiwan, 2011, and doctoral program in Pajajaran University, 2013. Many work experiences of Dr. Ferry, and we already know Dr. Ferry has published some papers that were published as author or co-author in national and international journal. And also, Dr. Ferry is a member of some organizations such as INESO, EAU, AUA, CU, Endurology Society, ICS, UAA, APSU, and ASCO. And now, Dr. Ferry is head of urology training program at Pajajaran University at the present. So, Dr. Ferry, you might start the session. Time is yours. Thank you.
Thank you, Dr. Linggar, for your introduction. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. Again, my name is Ferry Safriadi from Urology Department, Faculty of Medicine Pajajaran University, Hasan Sadikin Hospital, Bandung, as your moderator today. Ladies and gentlemen, esteemed participant and distinguished speaker, welcome to Treatment Across the Prostate Cancer Continuum, Precision Medicine Revolution webinar. This event is Johnson & Johnson initiated collaboration with Indonesian Urological Association. And I think this is it's with great pleasure and a sense of profound responsibility that we gather here to delve into the most critical healthcare topics affecting millions of men worldwide. Today, we embark on a journey to sharing and discuss the ideas and experiences in order to increase awareness and provide recent update and knowledge of advanced prostate cancer management strategies. Let us begin this webinar with enthusiasm, determination, and shared commitment to making a meaningful difference. We have three distinguished speakers today. First, Dr. Didik Setio Haryanto, PhD from Faculty of Medicine Gajah Mada University. Second, Associate Professor Edmund Cheong, PhD from Department of Surgery, Yong Lo Lin School of Medicine, National University of Singapore. And the third, Dr. Fauriski Febrian Prapiska from Adam Malik General Hospital, Medan. Let us begin. Please, Dr. Setio, Didik Setio, time is yours.
Thank you for the introduction, Dr. Ferry Safriadi. Nice to meet you. Assalamualaikum warahmatullahi wabarakatuh. And allow me to present in Bahasa Indonesia. Yeah, since this presentation is regarding the basic concept, so I'm worried it might be a bit difficult to deliver the point. Yeah. Pertama-tama saya ucapkan terima kasih kepada Ikatan Ahli Urologi yang memberikan kesempatan kepada saya dan juga kepada PT Johnson & Johnson. Ya. Baik, topik yang akan kita coba bahas di sini adalah tentang BRCA mutation pada kanker prostat. Ya. Jadi kalau kita selama ini mendengar BRCA itu sebuah gen, ya. Tetapi itu berkaitan dengan kejadian kanker payudara. Kalau tidak kanker payudara, biasa kanker ovarium. Ya, itu miliknya perempuan, ya, genitalia feminim. Tetapi ternyata untuk organ genitalia laki-laki nggak mau kalah, ya. Nampaknya juga ingin diteliti. Ternyata ada peran dari BRCA ini, ya. Tapi kalau kita sebelumnya, kalau misalnya kita cermati, ya, BRCA ini sebetulnya kan singkatan dari breast cancer gene, ya. Jadi kesannya ini kok breast cancer, ada kata cancernya, ya memang karena dia ditemukan pada saat pertama pada pasien dengan breast cancer. Tetapi sebetulnya hakikatnya ini adalah gen baik. Dia itu adalah gen yang baik. Nah, nanti kita akan coba membahas, ya, kenapa dia dari baik sampai menjadi mutasi, sampai kehadiran atau informasi tentang BRCA ini malah diharapkan ketika misalnya kita akan memberikan pengobatan, begitu. Ya, izin menyampaikan disclaimer bahwa ini semata hanya untuk pendidikan, tidak ada unsur atau tujuan untuk promosi. Nah, saya rasa ini bisa kita percepat, ya, karena ini saya rasa kita semua sudah cukup familiar dari pertama pasien hadir, kemudian dari pemeriksaan klinis, imaging. Nah, inti adalah aspek di kami yang akan kami bahas lebih dalam di sini, ya. Ya, jadi untuk patologi diagnosis di sini, ya, kita bisa mendapatkan berbagai macam tipe spesimen kalau yang ke kami, ya. Bisa itu turp, ya, bisa dari open, ya, dari reseksi, atau bisa juga dari biopsi, begitu, ya. Nah, tentu kadang-kadang kita agak ragu-ragu apakah dia sudah invasif, ya, karena kalau hallmark sebuah keganasan itu adalah dia harus sudah invasif ke stroma, ya, dia selnya sudah mulai nakal nembus ke stroma. Kalau dia masih ada di lingkaran di duktusnya saja, ya kita anggap itu masih sebagai yang in situ sebagai contohnya. Nah, oleh karena itu kadang-kadang kita masih perlu membutuhkan imunohistokimia, apakah dia sudah invasif ataukah basal selnya sudah tertembus, ya kita perlu imunohistokimia, ya. Kemudian yang ini marak, ya, yaitu adalah BRCA testing, ya. Nah, nanti akan kita bahas di sini. Ya, mungkin ini yang pertama, ya. Jadi ini adalah misalnya ada normal prostat, di sini ada paparan karsinogenesis, ya. Terus kemudian terjadi BRCA, ya, mutasi BRCA di sini. Apakah betul di sini PARP inhibitor, ya, bisa diberikan? Nah, tentu ini akan menjadi pertanyaan. Ini harus ada biomarkernya, yaitu kita harus bisa mendapatkan informasi apakah pasien ini ada mutasi BRCA-nya, ya. Terus kemudian kita perlu berarti ada suatu istilahnya genetic testing. Nah, tentu untuk semua ini yang kita perlukan apa? Dari pertama diagnosis hingga nanti melakukan genetic testing itu kita perlu sampel yang baik ya. Nah, oleh karena itu nanti kita akan berputar kepada pembahasan. Sekali lagi saya ulangi, kita sepakat dulu BRCA dulu ya. Kemudian nanti kita akan dengar ada PARP inhibitor, ada PARP itu sendiri, dan nanti ada berbagai macam metode atau sampel bagaimana manajemennya. Ya, kita ketahui ya, jadi kita tidak bisa terhindar dari paparan yang sifatnya itu merusak DNA ya. Karena apa ya, memang di kehidupan kita sehari-hari itu bisa namanya UV light atau mungkin X-ray ya, ROS dan sebagainya itu akan merusak DNA. Tetapi kita tidak bisa menghindarinya, tetapi untungnya kita punya sebuah gen-gen ya dalam tubuh kita itu yang punya peran untuk memperbaiki, alhamdulillahnya ya. Nah, di sini mulai kita perlu cermati ya. Mungkin saya akan mencoba pelan-pelan di sini. Jadi kerusakan DNA itu bisa bermacam-macam. Kalau yang di atas itu ya, type of DNA damage ya, itu dari yang single ya, bulky adduct sampai itu mismatch dan sebagainya. Yang terakhir ada double strand break. Saya akan fokus ya, kita akan fokus saja pada yang single lesion atau single strand break ini atau putus satu. Saya mau mengatakan ini supaya lebih gampang dalam bahasa Indonesia, ini putus satu. Kemudian saya loncat ke sini, ada namanya putus dua. Bayangkan seperti untai kalung ya, di mana kalau ini ada talinya putus dua dan putus satu. Ya, di sini ada mekanismenya. Ya, jadi DNA repair pathway itu ada bermacam-macam yang ada di bawah ini. Sekali lagi, kami akan fokus pada yang single maupun yang double. Nah, nanti akan kita bahas ya, itu mekanismenya namanya apa atau pathway-nya ya. Kemudian nanti ada juga cadangan kalau misalnya itu tidak mampu untuk melakukan ya. Lanjut ya, karena tadi kita sepakat akan membahas pada yang single dan double, saya lingkari di sini ya, bahwa kita mulai familiar di sini. Ketika ada single ya, maka itu ada suatu mekanismenya. Saya ucapkan di sini ada si tukang mekaniknya, namanya Mas Prapto, biar gampang ya. PARP saya sampaikan sebagai Mas Prapto. Mas Prapto ini pertama-tama gen ini itu sebagai sensor. Oh, ada kerusakan, kemudian dia sebagai transducer, kemudian di efektornya ya eksekusi, nanti dia ada gen XRCC1 untuk DNA repair. Tetapi ini untuk yang single. Berarti kita simpan dulu ya, berarti Mas Prapto itu punya peran pada yang memperbaiki tangga yang putusnya satu. Kita ke sini, kita ke yang double strand break ya, atau tangganya putus dua. Sangat kompleks sebetulnya, tetapi ingin saya coba sederhanakan ya. Perannya di sini adalah Mbak BRCA atau BRCA 12 ini, BRCA 12 ini, Mbak BRCA itu spesialis dia. Spesialis memperbaiki tangga yang putusnya dua begitu. Nah, berarti sekarang kita punya poin yang kita bisa simpan. Kalau dua putus, yang dandani itu adalah Mbak BRCA. Kalau putus satu, Mas Prapto. Nah, mari kita coba ya telaah lebih dalam. Jadi ketika misalnya ada kerusakan DNA pada normal sel ya, ini kita belum sampai ke kanker, kita pada normal sel dulu. Ketika misalnya ada kerusakan DNA ya, tadi kami sampaikan awal dia akan terjadi single strand break, putus satu ya. Terus kemudian bisa juga yang double strand break ya. Tetapi saya mau fokus dulu pertama, nanti kita ke yang single strand break dulu. Ya, apa yang terjadi? Nah, Mas Prapto datang. Dia akan memperbaiki putus satu ini ya, sehingga mekanismenya ya namanya base excision repair. Ya, atau ya BER, tapi BER ini tapi nggak usah terlalu ditelaah atau disimpan ya, tapi ini nggak begitu karena kalimat ini atau kata ini tidak begitu banyak keluar nanti. Yang penting adalah PARP. Mas Prapto dia dah hadir pada yang putus satu. Kita coba di mana peran dari Mas Prapto ini ya. Jadi ini adalah normalnya ya, contohnya ini. Kemudian dia misalnya ada DNA, kemudian ada paparan, misalnya ada ROS ya. Terus kemudian dia rusak, putus satu. Apa yang terjadi? Nah, si Mas Prapto ini, maka dia akan datang. datang kemudian menganalisis, menginvestigasi, ini saya rapikan dulu ya, saya poles-poles dulu ya, kemudian ini kayaknya perlu disemen ya, perlu ditambah ini biar cantik. Artinya dia mereparasi dulu ya. Terus kemudian nanti dia akan berinteraksi dengan XRCC1, kemudian dengan ligase 3 dan polimerase beta ya, kemudian akan terbentuklah namanya poly ADP reverse formation ya. Nah, di sini dia sudah mulai akan memperbaiki ya. Nah, akan terjadi seperti ini ya. Nah, akan terjadi sebuah DNA yang tereparasi, akan terjadi sebuah DNA yang seperti semula, begitu. Tetapi ini berlaku untuk yang satu, begitu ya. Nah, lalu apa yang terjadi ketika misalnya dia putusnya 2? Tadi sudah kita singgung bahwa Mbak Braka dia spesialis pada yang putus 2. Maka dia akan hadir Mbak Braka 1 ya. Kemudian nanti ada Mbak Braka 2 ya. Yuk kita perbaiki. Nah, ini yang ingin saya ajak kita semua ya untuk familiar. Ada istilah homolog recombination repair atau nanti akan kita singkat seterusnya sebagai HRR. HRR atau HRR ya, itu berarti sebuah mekanisme. Bayangkanlah ini adalah sebuah biro jasanya. Biro jasanya itu dia punya orang tentunya. Dia memperbaiki putus 2 ya. Dia punya orang-orang banyak, salah satunya Mbak Braka, begitu ya. Jadi mekanismenya sekali lagi adalah HRR, yang memperbaiki dia adalah Mbak Braka. Sekali lagi berarti double strand break, perannya adalah Mbak Braka, bironya atau mekanismenya namanya homolog recombination repair. Mari kita lihat bedanya di mana. Homolog recombination repair ya, jadi misalnya seperti awal tadi ada kerusakan DNA, putus 2 dia, jedet begitu ya. Nah, kemudian apa yang terjadi? Nah, Mbak Braka 1 dia itu akan mencoba menginvestigasi, melihat, merapikan ya. Kemudian apa yang harus dilakukan? Ya tentu dia akan memperbaiki lebih detail lagi ya. Karena apa? Seperti namanya, dia homolog recombination repair. Dia itu sebuah mekanisme perbaikan DNA yang bisa dibilang paling sempurna di antara semuanya. Karena apa? Karena dia mengambil dari homolognya, dari kromatid sisternya itu, dari homolog kromosomnya itu. Sebagai contohnya, analognya begini. Misal mobil kendaraan kita ya, mobil kita itu keserempet motor naudzubillah ya. Kemudian spion sebelah kanan kita itu lepas pecah berkeping-keping. Kita nggak punya asuransi misalnya, dan kita nggak punya uang untuk membeli spion begitu ya, maka kita akan memperbaiki itu. Kita niat banget ya, pecahannya kita lem ya begitu. Nah, tapi kita kan butuh contoh, maka kita akan ke tetangga kita yang punya mobil sama, tahunnya sama ya, spion sebelah kanan. Maka contohnya itu ya, itu ada di homolognya itu, di kromosomnya itu. Nah, inilah ya, makanya dikatakan sebagai homolog recombination repair karena dia itu akan memperbaiki seperti cetakan aslinya di awal. Maka dia ada mekanisme yang sempurna di sini ya, yang disebut sebagai strand inversion dan sintesis. Jadi nanti ya, mungkin saya ulangi begini, harapannya yang cetakannya, yang punya tetangga masih utuh ini, dia nanti akan memperbaiki ke sini. Yang pinky ini akan ke merah. Yang hijau ini nanti akan ke biru. Harapannya seperti itu. Tetapi mereka itu punya mekanisme yang sangat-sangat kompleks dan mereka itu sangat baik ya. Maka dia akan ke sana ya, membentuk loop. Kemudian yang ini akan ke sini ya, nanti dia akan ke sana. Intinya adalah akan terbentuk sebuah homolog yang DNA repair yang akan sama seperti asalnya. Sehingga dikatakan sebagai ini itu metode yang paling bisa dikatakan paling mendekati sempurna untuk memperbaiki DNA. Nah, kita ketahui bahwa ternyata perannya dari Braka yang diselenggarakan oleh SRR ini sangat kompleks dan sangat baik. Begitu. Baik. Nah, tadi kita sudah tahu konsep tentang mekanisme penyembuhan atau reparasi DNA baik yang single atau yang double. Nah, sekarang kita masuk kalau misalnya si Mbak Brakanya itu mutasi. Nah, apa yang terjadi? Mungkin saya masuk dulu kepada definisi mutasi dulu. DNA mutasi itu berarti dia itu urutannya ya, contohnya begini analognya. Saya memasak, kemudian saya melihat resep, contekan resep. Urutannya adalah pertama minyak, bawang, merica, dan seterusnya, tetapi saya lupa tidak membubuhkan garam misalnya. Tentu nanti yang menerima masakan bilang ini anyep, flat seperti itu rasanya. Atau saya salah menukar gula menjadi misalnya apa ya, sambal. Tentu akan rasanya juga akan lain. Jadi dengan menambah, mengurangi atau salah urutan itu mutasi. Proses saya itu salah urutannya, itu sudah mutasi. Dampaknya apa? Ya tentunya dampaknya akan rasa yang berlainan dan tentu juga akan menjadikan sebuah misalnya banyak hal misalnya di tubuh bisa jadi kanker atau sebagainya. Nah, kita sekarang tahu konsep mutasi. Nah, sebelum masuk ke beragam mutasi ya, kita kenalkan dulu ada istilahnya mutasi itu bisa germline atau somatik ya. Nah, kalau yang germline misalnya begini analognya. Ada di Jogja misalnya terkenal dengan gudeg ya. Dari gudegnya itu sangat pede banget bilang resep kuno gudeg turun temurun begitu ya untuk nilai jualnya. Tetapi di germline ini ya, di resep yang di gudeg ini dari nenek moyang dulu itu sudah salah. Ternyata dia itu nulisnya lupa menambahkan misalnya gula Jawa misalnya ya. Tentu anak dan turun-temurunnya sampai cucu cicitnya itu ketika menurunkan membuat cabang, maka akan mendapatkan sebuah rasa yang sama. Dia tidak gudeg yang tidak manis, misalnya seperti itu ya. Kalau Jogja kan manis ya. Loh ini kok Jogjanya kok ala-ala malah Sumatera, misalnya seperti itu ya. Nah, jadi itu udah konsepnya salah dari awal. Itu germline mutation ya. Resepnya dari awal sudah salah, turunkan sampai terus itu akan salah. Lain halnya dengan somatic mutation. Neneknya itu betul ya, resepnya betul turun temurun. Nah, ada suatu ketika turunan yang ternyata menulisnya, menyalinnya dia salah. Ya berarti salahnya di dia aja, tetapi cabang-cabang lain dia nggak salah. Resepnya rasanya sama, gudeg manis. Tetapi kalau yang misalnya yang salah ini, makanya gudegnya jadi gudeg nano-nano misalnya seperti itu. Nah, itu contoh dari konsep germline dan somatic mutation. Nah, tentang BRCA ini pada prostate cancer ya ternyata banyak sekali yang berhubungan dengan seperti genome instability dari sebuah prostate cancer ya di sini ya. Tetapi ingin kita soroti saja pada BRCA, pada BRCA ternyata itu menyumbang sekiranya kurang lebih 23% ya. Baik. Nah, sekarang tadi mutasi BRCA ya. Berarti ini Mbak BRCA-nya yang tadi diselenggarakan oleh HRR itu dia nggak mampu, dia nggak ada. Berarti bagaimana? Apa yang terjadi? Misalnya begitu, berarti nggak ada dong yang bisa memperbaiki dua ini. Maka akan ada mekanisme lain, ya, bukan HRR lagi mekanismenya. Maka ada yang disebut sebagai non-homolog end joining. Jadi mekanisme lain selain HRR ketika BRCA tidak hadir begitu ya. Nah, ini kita bahas tentang non-homolog end joining atau NHEJ ini ya. Jadi ini sama konsepnya, ada dua putus jedet-jedet begitu ya. Nah, maaf. Nah, ini ada yang ngelembereh ya bahasa Jawanya itu ngelawir gitu. Ya sudah, kerugiannya pada NHEJ ini dia itu tidak merapikan seperti BRCA. Mbak BRCA itu rapi. Mbak dia seperti prakarya ya dipotong rapi seperti tapi dia enggak. NHEJ itu enggak, asal comot aja potong yuk sambung. Nah seperti itu ya, maka ini ada kerugiannya meskipun dia sepertinya tersambung terreparasi tetapi dia itu condong untuk rusak ya, maka dia bisa nanti malah bisa mati, DNA-nya juga akan bisa rusak terus-menerus dan akan bisa mungkin jadi kanker atau malah jadi mati seperti itu ya. Nah, itulah konsep dari pengganti si HRR itu ya, NHEJ. Nah, sekarang kita masuk pada BRCA ya. Jadi kalau misalnya BRCA misalnya dia itu ditemukan pada yang germline ya, ada turunannya, ternyata dia menyumbang sekitar 7 kali untuk terjadinya prostate cancer ya. Ya, ini ingin saya singkat saja pada intinya, kita melihat point of view-nya dari prediktif dulu. Dengan kehadiran BRCA mutation, ini bagi seorang penemu obat, ini adalah suatu terobosan. Berarti dengan biomarker tertentu, yaitu munculnya BRCA, maka bisa ada terapi yang bisa diberikan berarti disebut sebagai target terapi, ya PARP inhibitor ini sebetulnya ya. Ini konsep kalau misalnya sebagai predictive marker. Tetapi kalau misalnya sebagai prognostic marker, kita tidak memandang ini ada obatnya tidak ya. Sebagai prognostic marker, jadi ketika misalnya ditemukan BRCA mutation, maka dia prognostiknya itu lebih buruk dibanding dengan yang prostate cancer yang dia tanpa BRCA mutation seperti itu. Mungkin saya cepatkan saja. Ya, untuk menjawab ini saya rasa lebih enak untuk slide setelahnya, tapi intinya adalah ini memang paling banyak BRCA1 dan BRCA2 mutasinya ya, nanti diikuti yang lainnya. Tetapi tadi saya bicara tentang HRR. Itu bironya. Mbak Braka kerja di situ, tetapi temannya Mbak Braka ada juga ya, namanya macam-macam ya. Nah, ternyata nanti ya, saya dulu ya. Mungkin akan saya skip dulu di sini. Nah, kita sekarang masuk ke ada istilahnya BRCAness. Tadi saya sampaikan bahwa ini anggaplah sebuah kereta HRR namanya. Semua punya tugas sama, akan menyampaikan kit untuk mereparasi DNA. Ya, ternyata tadi saya sampaikan juga ya, BRCA itu nggak sendirian di biro HRR atau kereta HRR. Dia ada ATM, ya namanya Mas Atmo, Mas ATR apa ya, pesawat ATR, Mbak Ciki 1, Ciki 2 dan seterusnya gitu ya. Itu teman-temannya Mbak BRCA ya. Nah, artinya apa? Bahwa ketika misalnya di gen lain ya, meskipun dalam satu HRR ya kan ada banyak nih ya, dia bisa mutasi ya. Nah, tetapi BRCA-nya nggak mutasi. Nah, itulah disebut sebagai BRCAness. Artinya bahwa ada salah satu gen di HRR yang mana dia mutasi atau defect, tapi BRCA-nya nggak ngapa-ngapain. Nah, ini tetap punya kemampuan bahwa nanti apakah PARP inhibitor itu juga bisa diberikan, ya. Tetapi ya nggak semua loh ternyata bahwa yang terjadi defect atau mutasi dari teman-temannya Mbak Braka itu meskipun ada, tetapi belum berarti bahwa punya manfaat yang baik ketika diberikan PARP inhibitor. Mudah-mudahan tidak membingungkan di sini ya. Intinya saja adalah bahwa banyak sekali HRR gennya yang ada di sini, terkenal adalah BRCA, tetapi yang lainnya itu juga bisa berperan, tetapi biasanya belum tentu misalnya yang ini itu bisa diberikan PARP inhibitor. Intinya adalah seperti itu. Nah, tadi saya sampaikan BRCAness adalah kerusakan atau damage dari komponen HRR, temannya Mbak Braka, ya, tetapi dia bukan, tapi BRCA-nya nggak apa-apa, begitu ya. Nah, itu disebut sebagai ya HRR yang defisien atau defect ya. Baik, nah ternyata selain BRCA juga ada yang tadi ATM itu adalah second most common ya. Jadi yang ATM Mas Atmo itu selain Mbak BRCA, Mas Atmo itu juga sering terjadi mutasi. Maka ketika terjadi mutasi ini PARP mungkin bisa diberikan, tetapi yang ini adalah less common ya. Nah, istilah ini adalah BRCAness, sekali lagi bahwa ada selain BRCA yang mutasi, tapi juga bisa menyumbang nanti ke terjadinya kanker dan sekaligus bisa diberikan obat misalnya PARP inhibitor ini. Nah, sekarang kita masuk ke dalam penggunaan PARP inhibitor, tapi konsepnya saya tidak karena ini terapi, nanti klinisi akan lebih mahir, tapi saya akan masuk ke dalam istilah synthetic lethality atau di mana PARP inhibitor ini diberikan. Ya, tadi kita sepakat ya. Tadi kan kita normal bicara tentang anormal ya, sel normal. Kalau ini adalah sel kanker yang sudah diterapi oleh mungkin oleh efek dari tubuh kita ataukah dari terapi kanker itu sendiri ya dengan agen-agen kemoradiasi misalnya, maka si sel kanker itu juga bisa terjadi kerusakan DNA ya. Tetapi masalahnya ya BRCA-nya nggak ada mutasi, Mbak BRCA nggak bisa memperbaiki. Ingat bahwa mau PARP mau BRCA itu dia nggak peduli bahwa ini sel kanker atau sel sehat ya. Jadi dia bisa tetap memperbaiki. Tetapi pada konsep ini adalah pada sel kanker yang mana BRCA-nya nggak ada. Begitu ya. Jadi dia nggak bisa memperbaiki kalau misalnya yang double. Nah, ketika diterapi sel kanker itu, maka bisa terjadi juga single strand break. Jedet. Dia putus satu. Maka tadi kita pikir, nih Mas Prapto mau datang nih, ya. Dia akan terdatang Mas Praptonya. Tapi ternyata PARP inhibitor diberikan Hei Mas Prapto, kamu jangan hadir. Kamu jangan hadir ke sini, tendanglah. Maka dia akan tetap single. Kalau single tidak diobati, lompat akan terjadi yang double. Tetapi double tadi gimana? Double Braka harusnya mengobati, tetapi Braka nggak bisa hadir di sini. Maka ya itu berarti apa yang terjadi? Maka pakai konsep lain, yaitu adalah yang NHEJ, yang non-homolog enjoining. Tetapi tadi kita sepakat bahwa NHEJ nanti lama-lama diamkan aja akan mati, karena tadi kita sepakat bahwa nyambungnya ala kadarnya, sehingga nanti dia akan mati sendiri. Makalah itu yang disebut sebagai synthetic lethality. Inilah peran dari obat PARP inhibitor. Jadi diberikan ketika misalnya Brakanya mutasi karena dia nggak bisa ngapa-ngapa. Tapi Mas Prapto ini yang bahaya nih. Kalau misalnya si DNA-nya single pada kanker itu ada, Mas Praptonya hadir, tetap hidup dong dia nanti, ya begitu. Nah ini juga analogi yang lain. Misalnya sel normal. Jadi misalnya Braka dan PARP ini menyepeda bareng ya. Tentu dia akan terjadi, ya ini normalnya, sel akan tetap hidup ya. Nah misalnya pada kasus 1, PARP inhibitor itu diberikan pada Braka yang mutasi. Ya, ini Brakanya mutasi, dia nggak bisa ngayuh ya. Tapi ada Mas Prapto, kok kualik ya, ya udah malah PARP-nya, kok malah ibu-ibu yang ini, PARP-nya masih bisa ngayuh. Apa yang terjadi? Ya, ini diberi PARP inhibitor, tapi sebelumnya misalnya ya, ini misalnya mutasi, tapi PARP-nya masih bisa jalan, tetap bisa jalan dia, stabil, viable, masih jadi sel kanker. Tetapi ketika dia diberi PARP inhibitor, maka dia tidak akan bisa jalan, dia akan stop, karena dia akan di stop, dan ini nggak bisa ngayuh, maka ya sudah akan stop. Kasus kedua, misalnya pada normal sel, apa yang terjadi? Ini Brakanya, ini sel normal, ini Brakanya nggak apa-apa ya, tapi diberikan PARP inhibitor, ya nggak ada manfaatnya, ya. Jadi tetap aja dia bisa jalan, ya. Karena apa? Meskipun ini diberi, ya nggak bisa ngayuh, tapi Brakanya dia tetap jalan, tetap akan bisa jalan selnya. Kasus berikutnya, misalnya pada yang PARP inhibitornya diberikan pada yang PARP yang defisien, ini nggak ada, ya. Karena apa yang terjadi? Ya sami mawon, asal salah satunya itu bisa jalan, ya dia akan tetap bisa jadi tumbuh selnya seperti itu ya. Nah itulah konsep dari synthetic lethality ya. Jadi intinya ada dua yang sifatnya itu non letal ya. Awalnya satu-satunya itu biasa-biasa saja, tapi kalau digabung malah jadi letal. Skema analog gampangnya begini. Kita punya kamar, ada 2 lampu, tetapi saklarnya beda-beda on off-nya. Suatu ketika, kalau misalnya lampunya mati satu, ceklek, oh berarti kita masih bisa menghidupkan pakai lampu yang satunya dengan saklar yang lainnya kan, karena saklarnya terpisah, kita masih bisa membaca ya. Tapi suatu ketika misalnya lampunya mati dua-duanya, berarti kan nggak bisa apa-apa. Nah itulah konsep dari synthetic lethality gitu. Nah kita sekarang masuk ke tisu sampel ya. Saya rasa ini mungkin agak kita cepatkan bahwa intinya bisa dari darah dan bisa dari jaringan. Tapi semua ada plus minusnya. Ketika dari darah, dia mungkin hanya bisa mendeteksi ketika itu germline. Ya, tapi kemudian kalau misalnya jaringan, kita bisa mengcapture bisa dua-duanya. Bisa germline maupun yang somatik. Ya, intinya mungkin seperti itu. Jadi keuntungannya kalau misalnya menggunakan jaringan tumor, ya itu kita akan bisa mendapatkan dua-duanya. Ya. Ini ada sebuah saya ambil di jurnal, ada sebuah kayak rekomendasi ya, atau algoritma bahwa untuk yang low middle income kayak kita ya. Jadi bagaimana? Misalnya dari pertama ada yang metastatic castration resistant prostate cancer ya. Apakah dia nanti ada tisu ya? Misalnya ada, misalnya memungkinkan tisu biopsi, rebiopsi, kalau bisa kalau tidak bisa ya pakai archive, pakai sampel yang dulu misalnya yang tersimpan di PA. Itu bisa digunakan. Tetapi kalau misalnya ada rebiopsi bisa dilakukan, lebih baik memakai fresh frozen atau jaringan yang frost ya, tidak dibekukan atau tidak ditanam dalam parafin begitu ya. Terus kemudian dari arsip ini ya, tentu ada pretest counseling ya. Nanti apakah terjadi somatic mutation? Jika ya bisa dilakukan inisiasi terapi dengan PARP inhibitor. Kalau misalnya tidak terdeteksi, mungkin bisa dicek yang temannya Mbak Braka tadi itu, ya, dan SRR gen lainnya, dan seterusnya. Saya rasa ini akan dijelaskan nanti oleh para pembicara berikutnya, ya. Nah, kemudian di sini mungkin karena PPT-nya nanti akan bisa dokter-dokter dan Prof dapatkan ya. Jadi saya rasa ini mengulang saja pada laboratorium itu paling penting itu justru pada fase preanalitiknya ini ya. Ketika dokter nanti salah misalnya mencelupkan cairan fiksasinya atau itu akan menjadi masalah ya. Ini beberapa akan saya sampaikan tentang pitfall ya. Dari aspek preanalitik. Preanalitik itu berarti pada saat dokter misalnya dari ngambil sampel, kemudian dokter akan melakukan pengawetan pada jaringan di situ. Nah, itu kita anggap sebagai yang preanalitik ya. Jadi kadang-kadang misalnya di sini ya metastatik tisu, hati-hati pada yang metastatik tisu ya pada bone. Ketika dokter misalnya mengambil dari bone, dokter atau PA-nya kemudian tidak cermat, dia itu akan melakukan dekalsifikasi dari tulang itu dengan cairan misalnya sitrat. Nah, itu akan merusak DNA-nya ya. Jadi itu akan membuat negatif, pasti akan negatif karena DNA yang kita periksa untuk BRCA ini akan rusak seperti itu. Jadi kita perlu hati-hati ya. Kita ingatkan kembali para klinisi bahwa mengawetkan jaringan ya itu tidak dengan alkohol, tidak dengan cairan lainnya, NaCl dan sebagainya, harus dengan netral buffer formalin ya. Tentu ketika misalnya itu ada metastasisnya, harap misalnya ada dokter PA di sini yang hadir ya, kita perlu ganti, jangan dengan dekalsifikasi misalnya sitrat, formiat dan lainnya, tapi kita gunakan EDTA. Berikutnya juga misalnya pada langsung saja, nah ini misal dokter mengambil dari tubuh pasien, kemudian diambil, mohon untuk segera masukkan ke dalam cairan formalin ya, ke dalam pot atau apapun, itu tidak lebih dari 20 menit. Karena jika lebih maka akan terjadi denaturasi ya, entah itu dari proteinnya atau dari DNA-nya seperti itu ya. Jadi kami harapkan ini kita sepakati segeralah untuk mencelupkan pada buffer formalin, maaf. Nah, ada sebuah studi ketika kita menggunakan archive, kita menggunakan arsip blok yang ada di PA, blok yang sudah lama, ada penelitian bahwa jika kita ada penelitian membandingkan 11 sampai 12 tahun, grupnya 5 sampai 7 tahun dan grup 1 sampai 2 tahun, ternyata itu tidak berubah untuk menghasilkan sebuah quality dari DNA-nya untuk bisa diperiksa BRCA-nya. Jadi kita cukup aman di sini, kita sampaikan. Jadi sampel yang lama itu bisa diperiksa untuk BRCA tes, ya. Tetapi tentu kita kadang berpikir ini profilnya sudah sama atau sudah berbeda, begitu. Ini kan masa lalu ya seperti itu. Nah ini adalah contoh juga bahwa cara-cara pengambilan spesimen ini ya ada bermacam-macam ya. Tetapi ternyata ya yang paling banyak itu adalah yang trephine biopsi ya. Ini yang pada metastasis di tulang biasanya ya. Ini malah paling banyak ya. Entah kenapa ya, mungkin karena tidak kecampur oleh jaringan normalnya ya. Seperti kayak radikal prostatektomi masih ada kelenjar normalnya misalnya. Apalagi TURP. TURP itu kadang-kadang kankernya itu tidak semua jadi kanker. Ada peralihan dari yang hyperplasia, kemudian ada PIN misalnya, high grade PIN, kemudian ada yang keganasannya ya. Kemudian yang paling kecil memang corneal biopsi atau biopsi itu kan mungkin dokter PA yang di sini sepakat bahwa kita sangat susah untuk mendiagnosis langsung sebagai kanker prostat itu pada biopsi yang kecil ya. Karena kelenjar yang cuma sedikit kecil dan kita kadang-kadang perlu IHK apakah ini sudah invasif atau tidak. Nah, maka ini kita sampaikan ternyata tuh radikal dan bahkan mungkin FNAP ya itu cukup bisa menghasilkan kualitas DNA yang baik ya. Kadang mereka ada yang bertanya juga kok bisa corneal sama-sama jarumnya dengan FNA kok malah banyak FNA-nya. Ya, kalau ini soalnya banyak tumornya, kalau yang ini kecampur atau sedikit anunya ya, sedikit selnya, banyak stromanya dibanding selnya, ya seperti itu. Ya. Nah, kita ulas kembali bahwa hati-hati pada sampel biopsi. Sampel biopsi itu kecil. Ketika dimasukkan ke dalam pot isi formalin, formalinnya nggak penuh, kadang-kadang nempel di sini. Nah, kadang-kadang setengah nempel, ya. Kita kan zaman sekarang itu kan ya senang yang setengah-setengah begitu ya. Kadang-kadang lupa, malahan masih nempel di atas atau malah nempel di dalam tapi di sisi dalam ya, ditutup yang sebelah dalam. Tidak kena formalin atau lupa dimasukkan. Yang paling benar adalah benar-benar tercelup dan sekali lagi jangan pernah kita melakukan fiksasi dengan alkohol karena itu akan rusak semua ya dan nanti rugi banget dari diagnosis juga tidak akan baik. Berikutnya misalnya kita mendapatkan sampel open prostatectomy atau reseksi prostat itu, kadang-kadang kita pede ya dengan plastik masukkan, sudah masuk ya. Begitu diletakkan di meja, ternyata ini akan ada nyumbul seperti ini ya. Nah, kadang-kadang ini ternyata area yang misalnya ini yang ada mutasinya. Nah, tentu dia akan tidak terawetkan. Nah, harus hati-hati juga ya. Baik, nah kemudian ini saya rasa bisa kita cepatkan ya. Intinya saja memang kita perlu caranya dengan NGS ya, dan memang diprioritaskan ternyata adalah gennya itu BRCA1, BRCA2, dan sebetulnya ada ATM ya, tetapi ini tergantung dari obatnya. Misalnya pada obat tertentu dia hanya memfokuskan pada harus mutasi BRCA1, BRCA2, ada yang misalnya nggak peduli apapun, yang penting masuk dalam HRR itu bisa ya, tapi tergantung dari obatnya ya. Terus kemudian saya ingin membicarakan di sini bahwa tadi disampaikan tidak ada perbedaan kualitas DNA ketika yang umurnya dari blok parafin yang lama ya, tetapi harus dengan catatan dia itu disimpan pada tempat yang benar ya, misalnya dia dengan ber-AC ya, terus kemudian dia dihindari dari cahaya matahari ya, tentu dia kan bisa dipertanggungjawabkan ya. Ini adalah alurnya, saya rasa kita semua sudah sepakat ya, dari pertama sampai akhir ya. Mungkin ini hanya mengingatkan saja. Yang saya pada slide ini saya ingin menyampaikan bahwa ketika kita nanti melakukan pemeriksaan BRCA dengan NGS ya, kadang kita juga heran ya, NGS itu cost-nya kan tinggi ya, tapi ini banyak-banyak diminta juga ya, itu saya juga bingung nanti maintenance-nya gimana ya. Nah, yang paling penting juga adalah pada analisis BRCA itu sebetulnya nggak cuma keluar keluntung BRCA-nya ada, tetapi ternyata itu perlu bioinformatika. Jadi nanti meskipun ketemu ada BRCA-nya muncul, tapi dia variasi atau yang patogenik itu diklasifikasikan. Ada juga nanti mutasi yang dia tidak tahu ya. Jadi itu perlu bioinformatika. Jadi nggak sekedar cuma keluntung ada BRCA ya, tidak ya. Jadi nanti harus ada analisisnya ya. Ya itu dengan NGS ya, ini adalah yang terakhir. Jadi kita sepakat tadi bahwa tumor atau sampel apapun itu harus baik untuk diagnostik ya, karena berikutnya akan digunakan untuk pemeriksaan lanjutan, yaitu satunya adalah BRCA ya. Jadi blok jaringan yang tersimpan di laboratorium PA itu bisa digunakan ya, umurnya insya Allah tidak begitu berpengaruh ya, dan sesuai dengan dari College of American Pathologists itu bisa digunakan asal dia ditempatkan pada area yang baik ya. Terus kemudian ya genomic profiling itu tadi sebetulnya sudah kita sampaikan di depan. NGS merupakan cara atau metodenya ya untuk mengidentifikasi SRR itu. Kemudian diprioritaskan pada BRCA1 dan 2 atau mungkin ATM, tapi saya sampaikan tadi tergantung dari obatnya itu ya. Dan tentu ada genetic counseling tadi itu. Jadi nggak semata-mata langsung tes, tapi ada genetic counseling ketika misalnya ada terutama yang germline ya. Jadi apakah itu harus perlu genetic counseling, apa di kemudian hari dia akan mendapatkan tumor ataukah variasi saja dan sebagainya, itu perlu genetic counseling. Terima kasih, mungkin waktunya berlebih, mohon maaf kalau misalnya jadi belibet ya. Saya berharap semoga ada manfaatnya dan bisa diterima. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Oke, terima kasih Dr. Didik atas penjelasan presentasinya sangat jelas sekali tentang mekanisme BRCA dan bagaimana kita melakukan pemeriksaan agar hasilnya baik. Baik, kita lanjutkan. We continue to the second speaker, Professor Edmund Cheong. Will address the urologist perspective, current practice in genetic BRCA testing in CRPC. Time is yours, Professor.
Hello, good morning. Thank you for the very kind introduction. I'd like to thank the organizing committee for the very kind invitation for me to speak. So today, and of course, this is following a very interesting talk earlier. It showed the pathology of BRCA and the sample handling. So I will talk a little bit more about the sample issues also as part of the talk. But really today, I'm going to discuss more on the urologist perspective, as also the current practice of genetic testing in mCRPC, prostate cancer. So once again, it's very glad to see all of you here. I bring you greetings from Singapore, from the Department of Urology at National University Hospital, where I am right now, and also would like to declare my conflict of interest disclosures. So really, I'm going to talk on some of these aspects of what are current challenges of HR mutation testing in mCRPC. Of course, the common questions is why do we test, who do we test, when do we test, which genes do we test, what tests to do, and certainly how to interpret the test results and how to use them. So I'll be trying to address this along the way in my talk. Now, so as already heard by the previous speaker, we know that currently the interest is really in HR mutations is along the DNA repair pathways, and there are several DNA repair pathways that include the DMMR, which is a DNA mismatch repair pathway, where it results in hypermutation and microsatellite instability. And then there's the DSB, which is what we're interested in, where you have the DNA repair genes, either from germline or somatic mutations involving BRCA1, 2, ATM, etc. And then there's the loss of CDK12 or deficiency of mismatch repair genes as well. So there are several pathways that we look at for DNA repair. And already shown earlier, there are two seminal papers that we quote of why DNA repair genes is important in prostate cancer, because in the Pritchard paper, you can see that almost 12% of 692 patients with metastatic prostate cancer had germline DNA repair defects, and the commonest was BRCA2 at 44%, second was ATM, and then CHEK2, and then BRCA1 at 7%. And this was one of the important papers that tell us how important these DNA repair pathways are in prostate cancer. Now, what about, and also in the Robinson paper that was earlier shown in the previous speaker, we can see that as the patient progressed from MHSPC or metastatic hormone-sensitive prostate cancer to mCRPC, which is castrate-resistant state, you can see the number of mutations along the DNA pathway increases from 12% to 23. And this can be seen in 150 patients from the Robinson paper that almost up to 25% of patients will have this kind of mutations in their DNA pathways. So the population becomes enriched as they progress from along the disease from MHSPC to mCRPC. Again, when we talk about genetic testing in prostate cancer, we understand that there are two forms of genetic mutations in the HR pathway. One which has hereditary indications, which is the germline. This similar picture was shown by the earlier speaker, when patients can inherit this one mutated copy of the BRCA gene. And the other reason for testing is because of therapeutic indications for the use of PARP inhibitors. And this is shown mainly because of the somatic changes in the cancer cell itself in the prostate that changes the copies of having second somatic mutation results in the biallelic BRCA loss, and this constitutes the somatic gene abnormality. Now, what is all this in relevance to? Having known that the DNA repair pathway is so common in metastatic and prostate cancer and mCRPC, this was one of the first phase 3 randomized controlled trial called the PROFILE study that studied patients with mCRPC with disease progression on prior novel hormonal agents such as abiraterone or enzalutamide. And these patients were all screened with qualifying gene mutations in the HR mutation pathway. And this was done through the assay called the Foundation 1 next-gen sequencing test, and looked at 15 genes that include BRCA1, 2, ATM, and a number of other common genes in their tumor tissue, meaning somatic testing. And they were divided into cohort A and B, where cohort A comprises BRCA1, 2, and ATM that were randomized to olaparib twice a day versus physician's choice was usually back-to-back hormonal agents, which is also one of the novel hormonal agents, even though they have progressed in one of the prior ones. Then there's cohort B, which is all the other 12 genetic alterations, all randomized. And the primary endpoint was rPFS, or radiographic progression-free survival. So what we saw was that olaparib demonstrated a significant overall survival benefit, especially for cohort A, which was the BRCA1, 2 ATM cohort, versus physician's choice, which was another novel hormonal agent. And also, even after the patients cross over from the control to the treatment arm in olaparib, the final OS continued to show overall survival benefit. And the overall hazard ratio for cohort A was 0.96. So this was statistically significant. Now, beyond PROFOUND, which was patients who progressed on novel hormonal agents plus ADT, there were further trials, 3 trials that studied the treatment intensification of PARP inhibitors plus novel hormonal combination. And these were patients who progressed on ADT alone. That means just without novel hormonal agents, just ADT alone, and progressed and became mCRPC. Now, these 3 studies, called the PROPEL, MAGNITUDE, and TALAPRO respectively, had very similar design by randomizing patients to PARP inhibitors plus abiraterone, and the last one, TALAPRO-2, was PARP inhibitor plus enzalutamide versus the placebo plus the novel hormonal agent like abiraterone or enzalutamide alone. And the primary endpoint were largely all rPFS, radiographic progression-free survival. The PROPEL was different because they had all comers. They did not test for HR mutations, while MAGNITUDE was a study that looked into having stratifying patients who had HR mutation and BRCA1, 2 before they were randomized to the treatment arm versus control arm. In TALAPRO, there was a mixed population. They did have overall group without stratification, and they also did some patients testing with HR mutation. So these are largely similar design, but with some differences in terms of HR mutation testing prior to randomization. Now, I'd like to draw attention to MAGNITUDE, which was a double-blind, placebo-controlled randomized phase 3 trial for first-line mCRPC patients. They were allowed abiraterone acetate less than 4 months prior to randomization, prior to mCRPC, which is a short duration. And all patients were stratified looking at the HR mutation testing first, and this was done either using plasma or tissue or whole blood. So basically, they were looked into whether they are HR mutation positive versus negative. And the positive cohort and the negative cohort were both subject to randomization of niraparib plus abiraterone acetate versus placebo plus abiraterone acetate. And their primary endpoint was rPFS. So this was the testing flow where the controlled population was looked into the HR mutation test results, and those patients who had mCRPC first line were pre-screened with HR mutation using either the tissue blocks or blood for ctDNA. And if it's positive, they went under the randomized in the cohort, the first cohort. Now, so we can see from here that in the biomarker positive HR mutation, there were about over 400 patients randomized in this section, and about 159 were both tissue and plasma. About almost 1/3 was by tissue and another third by plasma alone. So this was interesting because there was a combination of both the tissue and plasma used, unlike the PROFOUND study. And so a very quick glance into the basic characteristic, baseline characteristic, most of them you can see 40% in both the treatment and control group were BRCA2 positive. BRCA1 comprised about 1.9 to 5.7%, and ATM was the next most common in the study with 20%, almost 20% in both arms. while check 2 was about 8.5 to 9.5%. So very briefly, the final result, the primary endpoint was met, where there was significant rPFS benefit of the combination therapy versus the placebo-controlled arm, with a significant reduction in risk of progression or death by 27%. And this is by both the central review and investigator, with the hazard ratio of 0.64 and 0.73 respectively. Now, so in the treatment landscape of metastatic prostate cancer, we can see that in MHSPC, we already have a lot of gold standard of care treatment with the novel hormonal agents, docetaxel, and more recently, the triplet therapy, docetaxel plus ADT plus either darolutamide or abiraterone, and for low volume prostate radiation. But MCRPC, we traditionally always had a single monotherapy, and this was used sequentially. And of course, we know that all these had OS benefit, like the novel hormonal agents, docetaxel, cabazitaxel, radium-223 in the older series, and olaparib based on PROfound, and lutetium PSMA based on the VISION trial. And more recently, this is new, where this is the use of combination with PARP-I plus NHA has started to come in as options for MCRPC. But notably, at this point, their primary endpoint was rPFS benefit, which was demonstrated in the trials, especially like Magnitude and Propel. So basically, we are entering an era of combination therapy and precision medicine also. So as you can see, is it prime time for precision medicine as alluded to by the previous speaker? The answer is yes, because with PROfound study and Magnitude, we could see that patients that are carefully selected based on HR mutation testing can benefit significantly in terms of overall survival and rPFS from these PARP inhibitor treatment. And this is probably the first and only demonstration of precision medicine in metastatic prostate cancer at this point, while the others are still on the road to precision medicine. So if you look at the latest NCCN guideline this year, for patients who are CRPC with imaging study showing positive for metastases, that means MCRPC, the recommendation is to perform HR mutation testing if it's not previously performed. And so the first recommendation that we can think about is when you have a patient who's on hormonal treatment, ADT, with or without PARP, with or without novel hormonal agents, and the patient has starting to rise, PSA started to rise and is approaching MCRPC, you can consider HR mutation testing. So the suggestion is not to wait until you diagnose MCRPC, but rather as the patient is approaching MCRPC, would be, in terms of when, would be the best time to start testing, because testing do take time. It takes an average of 3 to 4 weeks for the entire report to come back. So it does require some time. So the recommendation is when patients approaching MCRPC is a good time to test. Now, I apologize for this very busy slide, but it really summarizes the recommendation of the various current guidelines on the utility of testing, who to test, and what genes to test. So if you look at the NCCN guideline, which is the most broad, they recommend testing for metastatic prostate cancer, but even certain patients with high and very high risk localized prostate cancer, especially patients who are Ashkenazi Jews, strong family history with breast cancer, and preform ductal pathology. And they do recommend a fairly broad panel that include basically similar to what the PROfound study recommends, the BRCA1/2 ATM, and a few others like CHEK2, CDK12. For ESMO, they basically just talked about the recommendations for metastatic prostate cancer. For AUA, which is a few years old, they recommend for patients with metastatic MHSPC, regardless of age or family history, and also for MCRPC in view of PARP inhibitor test treatment. Now, there's a Philadelphia Prostate Cancer Consensus Conference in 2019, and these consensus was to recommend testing in patients with metastatic prostate cancer, either MHSPC castrate sensitive or castrate resistant, especially with a family history that is significant. and they recommend the priority genes for testing would be the BRCA1 and 2. Now, the latest EAU guidelines recommend for MCRPC, and they recommend also BRCA1, 2, and ATM. The APCCC 2019 consensus, most of the panelists agreed that newly diagnosed MSSPC would be the best time to test it, and most of them would agree to use testing with the gene panel, including HRM, especially BRCA1 and 2. So this summarizes the guidelines, current guidelines of what constitutes the recommendation for testing and who to test and what to test. Now, we know that in patients with MCRPC, the hit rate or the positive rate for HR mutation is somewhat around 23 to 25%. That was shown in the Robinson paper earlier. And out of that 25%, about half of them would be BRCA1 and 2, while half of them are non-BRCA mutated. And we know from the earlier speaker that HR mutation actually confers a poor prognosis, and patients with these mutations, germline BRCA1 and 2, are more likely to present with advanced disease, high Gleason score, nodal involvement, and metastases compared to the non-carriers. So basically, they present with more aggressive disease. And in the PROFOUND study, BRCA2, as you can see, was the most commonly detected at 8.7%, and the next most common was the CHEK12, and followed by ATM. BRCA1 constitutes about 1%, and this was based on the somatic screen of 2,790 over patients. Now, so the question, of course, is when we talk about who to screen, we talked about when the patient is approaching MCRPC would be the first most important indication, and possibly metastatic prostate cancer patients as well, based on the various guidelines. Then we talk about what genes to test. Now, of course, you can do the full panel of a 15 gene, and there are some other studies that do a lot more genes. However, please, for therapeutic indication, what must be borne in mind is what has been approved by the various regulatory authorities. So basically, the European authorities are a little bit lagging behind compared to the FDA, but they're very similar in terms of approval. So if we look at olaparib based on the PROFOUND study, the FDA approval was really for BRCA1, 2, and ATM, as well as the 12 other genes in cohort B, right? However, if you look at the combination therapy like olaparib plus abiraterone, the FDA approval was only just 2-3 months ago, and it was only for patients who had BRCA1 and 2. And for niraparib was based on Galahad and Magnitude. The approval was really for BRCA1 and 2 only, and rucaparib was based on Triton 2 and 3 studies, and the FDA approval was only for BRCA1 and 2. So this has to be borne in mind when we have intention to treat patients with the BRCA inhibitors, PARP inhibitors. So in terms of type of HR mutation profiling, I think the earlier speaker had also alluded to this. We have the option of tissue somatic testing, either from the prostate biopsy or prostate surgery like URP or prostatectomy, or the metastatic site biopsy. So these, and the commonest use are archival biopsies of primary tumor samples, often used for testing, but patients can undergo newly identified metastatic site biopsies or sample obtained through liquid biopsy methods. And the other option is blood, which is tests for germline DNA, and finally also circulating tumor DNA, also taken from the blood plasma. Now, in terms of the differences, I think there are some advantages and limitations of each. The germline testing, as mentioned earlier, germline mutations are detected reliably. Large panels are available to detect germline mutation MCRPC. However, the limitation is they are not able to detect somatic mutations. Now, somatic testing can detect both germline and somatic mutations. They can provide large panels, and large panels are available for such to test many genes. However, somatic testing is less sensitive and less robustly validated, and more robustly validated somatic testing is required. And finally, the plasma circulating tumor DNA. This can identify both germline and somatic testing mutations as well, and it's minimally invasive, so it's easy. But the only problem is there are some limitations which we'll look through, and it can miss germline variant if it's not sequencing the whole gene because of the small size of ctDNA. And later on, we'll talk a little bit about some of its limitations as well. But however, what we do know is that somatic testing identifies more patients who can benefit from PARP inhibitor than blood testing alone. Now, this was earlier shown, very similar slide was shown by the earlier speaker, where the HR, but I just want to show that the HR mutation testing involves multiple steps, from the sample preparation of the tumor to the blood, DNA extraction, as well as NGS sequencing, and finally molecular classification, reporting, and clinical decisions. There are multiple healthcare professionals involved, which includes the urologist, medical oncologist, nurse, or even medical geneticists, which will involve in patient consent, and through of course, the pathologist will come into play once the urologist or medical oncologist and nurse obtain the sample. And then, of course, there was the processing, which really requires the geneticists and genetic technologists. And finally, the reporting, which will involve everybody because there is a clinical decision to be made as well. Now, so based on the PROFOUND study in the phase 3 trial where they tested more than 4,000 men with MCRPC, you could see that this is the fallout rate, right? You could see that they started with these samples and there were a number of issues with the failing to meet pathology requirements. So you can see based on the quality of the DNA. And so as you go along, the sample fallout rate was quite significant. And overall, in the PROFOUND study, the overall tissue test failure rate was about 42.5%, based on the publication from Hussein. And these are the main reasons. 20% out of 42.5%, 20% was due to minimum DNA yield was not met. 11.7% was the sample requirements were not met, and 10.8% was failure during the NGS testing due to various DNA quality issues. And now the question, of course, then is what samples would be optimal if you are going to do somatic testing? We can see that the test success rate does decline with age. As you can see in the right column, when you have tissue samples that are less than a year old, they have the highest success rate, about 68%. 1 to 3 years, reasonable, 62.5%. 3 to 5 years, you possibly can get over 50% yield rate from genomic testing. But once you cross more than 5 years, although you can obtain samples, but you can see that as the years go, the sample success rate will drop. And similarly, there are differences in the type of tissue that is obtained that can actually contribute the yield of the DNA. So in the primary prostate gland, which is mainly from core biopsies, you can see this is one of the lowest, 6.2%, because it really depends on the number of tissue samples that one obtains and the amount of quantity of cancer present. And of course, if you look at overall metastatic site, it's higher. So if you obtain tissues, one of the highest would be that of if you obtain a whole lymph node, that would actually give better yield in terms of DNA sample and amount of tissue for the pathologist, as well as the processing to assess. The other solid organ tissue may actually yield more. Yeah, and also here you can see core biopsy tissue is probably the lowest yield because of the sample amount involved. But you happen to do a TURP for palliative reasons, or this patient had prior radical prostatectomy, you can see that the yield is going to be much higher in the 70s to over 70%. So really, if we are talking about higher success of yield based on the PROFOUND study, you can see that the tissue, the solid organ or the primary organ done with more tissue yield would actually be better in terms of getting more quality DNA. Now, so this is also to show that the sample processing has many, many requirements. I will not go through this in detail because this was very well explained by the previous speaker, from the requirements of fixation, sectioning, process and pathology review, DNA extraction, and then next-gen sequencing. All these have many specific requirements to ensure the quantity and quality of the DNA is available for the HR mutation testing. Now, I just want to show a little bit about some common companies that are being used in this day and age in our region for HR mutation or DNA testing. And of course, the most common would be Foundation One, which was the main company or vendor that was used by the PROFOUND study. However, this comes at a higher price. In Singapore, the price is quite high for this vendor to perform the DNA testing, and therefore we do not commonly use this. There are other companies involved. For example, in our National University Hospital, we are in the National Cancer Institute of Singapore, a National University Cancer Institute. We commonly have previously used Genome as one of the vendors. However, just to take note, this is when we use this vendor, there are some requirements. For example, the number of slides need to be more than 20 slides based on the number of cores. So it's not something very few slides that they need, but rather they do need a high quantity of slides. Another vendor we used was ACT Genomics, where they also require 5 to 20 unstained slides with a total surface area of 125 millimeters cubed. So these are a number of requirements. So with this understanding, as a urologist, this is something that I want to bring out, is that when we nowadays perform biopsy, we have to have HR mutation testing in mind, meaning the future in mind. Because when we do biopsies, these patients are either at the localized cancer stage or the metastatic hormone-sensitive stage, where we just diagnose and is unlikely to use PARP inhibitors at that time. So we do know that if we perform MRI-targeted prostate biopsy pathway, it may increase the yield of cancer tissues in the sampling compared to random sampling, because you're getting more concentration of cancer, especially cancer that's not obvious on clinical examination. And when the cancer is suspicious on clinical examination to be locally advanced, for example, a hard nodular prostate that is obviously advanced prostate cancer, in the past, what we used to do is to obtain 1 to 4 samples, or maybe even limited samples, to just diagnose the cancer, so that there's less risk of morbidity from the prostate samples, however, from the prostate biopsy. However, if to have the future in mind in this current age, we may want to consider as urologists to do more than limited biopsy calls to obtain diagnosis, but rather to plan ahead for the use of this future use of archival tissue for HR mutation testing. Because as you can see in the various companies, they do require many number of slides, from 12 to 20 slides, and that is not a small amount of tissue. And of course, obtaining fresh tissues from metastatic site or repeat prostate biopsy or palliative procedures such as TURP can be considered, which will have more yield. So as urologists, one of the considerations is to obtain more samples at the initial biopsy, so that it will facilitate future HR mutation testing. Now, in recognition that there are a number of difficulties and potential hurdles, and the need for standardization for HR genetic testing in MCRPC, in Singapore, we have came together as a multidisciplinary group to have a consensus of how we should do this. And this involved medical oncologists, urologists, pathologists, genetic counselors, to come together for a consensus. And we published this in our local journal, Annals Academy of Medicine, in last year, where we detailed for patients with MCRPC, what would be the optimal timing for testing of germline and somatic testing. And also we took the opportunity to address about genetic pre-test counseling, because we recognize that it's important for patients to understand, and sometimes their families, to understand the implications of genetic testing, as well as to understand the success and failure rates, so that because in Singapore, when they do genetic testing, is out of their own pocket costs, and sometimes patients do not understand that when they do a testing, the chance of having a positive test is probably around 20%, and 80% of the time, the test will yield negative, and therefore the cost would have already been paid. Now, so we have a pathway where we look at the feasibility of somatic tissue biopsy testing, whether from the primary or metastatic site, and we look at archival first, and whether it's adequate, and if it's inadequate, we move to plasma for ctDNA testing, and we also institute post-test counseling by a genetic counselor, because anybody who's got positive test has a high chance of germline positivity, and therefore these patients are recommended to have a post-test counseling if they are positive. Now, of course, somatic testing, if they are positive, we can actually use them. Germline testing are positive, we can actually use them for clinical decision-making for PARP inhibitors. So some of the recommendations that we talk about include routine clinical practice, such as taking a proper family history, informed consent, and we recommend that somatic testing is performed for all patients with metastatic cancer, best in metastatic prostate cancer, especially when they're progressing to mCRPC, not waiting for mCRPC to be diagnosed, but rather on the way to mCRPC. And of course, we talk about germline testing, as well as patient selection considerations such as strong family history, intraductal pathology, metastatic disease, or very high risk of localized prostate cancer. And of course, notably, relying on family history alone may miss patients, because now we do see that a good number of proportion of patients without family history can also harbor the HR mutation genetic defects in their tissue, especially, even in germline. Now, so and we recommend that urologists and medical oncologists who are treating these patients are appropriately trained in basic genetic counseling, not the detailed one that is done by genetic counselors, but at least to cover these elements of discussion that includes disease management, optimal downstream effects, insurance coverage, cost of further treatment, patient's overall clinical status, review of genetic discrimination legislation, which is applicable to Singapore, because we do have certain legislation in terms of genetic testing, and account for potential distress of unexpected results. So in my institution, in the National University Hospital and NCIS, which is National University Cancer Institute, I have drafted a protocol for my department, where patients on novel hormonal agents with PSA progression undergo a simple pretest counseling by the urologist or medical oncologist. And we look at the feasibility of somatic tissue testing based on archival tissues, and whether rebiopsy is an option, and look at the age, the tumor volume, and the number of cores. If it's not suitable, then we go into looking for ctDNA liquid biopsy. However, we also need to note that this is important to know what the PSA levels, how rapid is the rise in PSA, and the metastatic burden, because this has implications on the reliability of the testing for liquid biopsy. And if it's a no from somatic testing, we can go into germline testing, but we usually refer to a licensed genetic counseling clinic in our institution. And we also advocate, if the test is positive for somatic, we should have a post-test counseling by a genetic counselor down the road if they have a positive somatic testing. And then, of course, we work with the pathologist and look at patient consent. Now, so a few, and that constitutes our pathway. Now, when we talk about plasma cell-free DNA or circulating tumor DNA, there are some pitfalls that one must be cognizant of. Firstly, it can have false negative test results if you have very low serum PSA. That reflects a low tumor burden, because if there are very few tumor cells circulating in the bloodstream, then your yield may not be high. So you can see in this chart here, the yield is higher when there is a higher ctDNA fraction. So the higher fraction, the higher the accuracy. And of course, circulating tumor DNA are small sizes most of the time. We can miss germline variant because we're not sequencing the whole gene. So see, these are some of the pitfalls. Now, this is an interesting website that you can look into, ctdna.org. This is developed as a research tool, not so much a clinical use tool, by the Vancouver Prostate Institute in Prostate Center in Canada, and from Temple University in Finland. They have an online calculator to help you predict what is the likelihood that you're going to get a positive ctDNA percentage. So this is something useful, but certainly they declare that this is for research use only, but not so much for clinical use. But I thought this would be quite interesting, so that you reduce the chance of patients having to pay for the test but come out as a negative test. The other thing to take note, other than tumor burden, is to note that there are potential confounders to circulating tumor DNA from plasma. This is called the clonal hematopoiesis, clonal hematopoiesis of indeterminate potential, called CHIP. Now, this is a relatively newer entity that's been recognized as a source of biological noise to cell-free DNA analysis. Is because the majority of cell-free DNA, about 80%, arises from hematopoietic cells, and these normal hematopoietic cells can accumulate somatic mutations during aging, which can drive the clonal expansion of hematopoietic cells in the absence of dysplasia. Now, these are referred as CHIP, and they present as a potential confounding factor to early cancer detection assays. So this must be something we must be cognizant of. So lastly, I present a case to better illustrate how to use the test and interpret the test in a real-life scenario. I present an 82-year-old gentleman of mine, a patient of mine who had well-controlled hypertension, hypercholesteremia on statins, good controlled diabetes mellitus on metformin, and ischemic heart disease with coronary artery PCI done 15 years ago, but still having good ejection fraction on echo, is on anticoagulants like clopidogrel, Plavix, good ECOG status too. He has a family history of a younger brother having prostate cancer in the 70s. He presented with abnormal hemoglobin, low hemoglobin, H7.1, and low platelet counts on screening FBC. He had a hard nodular prostate. Initial PSA was 195, and no surprise, the biopsy shows a high Gleason score. Now, the MRI showed a locally advanced mass infiltrating the seminal vesicles, but not the lymph nodes. And the CT's thorax, abdomen, pelvis, thorax and abdomen did not show any visceral metastases, but certainly a widespread bone metastases. In the bone scan, you can see it's a super scan with multiple widespread bone metastases. This patient was started on LH-RH antagonist with a loading and monthly maintenance dose. At 1 month, the PSA dropped significantly from 195 to 0.41 with a good castrate testosterone level. He declined chemotherapy. Certainly, there was concern because it's low hemoglobin and what total low hemoglobin count. He started on apalutamide. Now, this was the graph showing his PSA response where he started apalutamide from 195. He had a good suppression for a good 15 months. And his hematological abnormalities recovered with no bone pain. The repeat CT showed, however, after 15 months, showed increased bone metastases in the long bones and skull with 4 new metastases, but no visceral metastases on the repeat CT scan. He was referred to medical oncologists to start docetaxel chemotherapy, but he could not tolerate after 1 cycle. Now, in this situation, what would you offer to treat his mCRPC? He has seen ADT plus apalutamide, which is a novel hormonal agent, plus he could not tolerate 1 cycle of chemotherapy docetaxel. Now, so we subjected this patient to a somatic testing where, based on the biopsy results, we sent 10 slides to be submitted. And however, based on this vendor, the ACT Genomics, it was not detected. Or rather, this is a hypothetical situation. It was not detected. The question is, what will you do next? Of course, we don't have a voting platform, but some considerations that we discussed was if you have a negative sample, because it was only 10 slides submitted, would you consider doing liquid biopsy using plasma ctDNA? Or would you consider germline testing because this patient does have family history and personal history of metastatic prostate cancer? Or we could also repeat the biopsy either from the bone, but as we heard in the earlier speakers, the bone requires decalcification first, make the yield will not be very certain, or repeat the prostate biopsy. However, if it's not feasible to do further HR mutation testing, we could consider the non-PAPI options because this patient did not show any deleterious genes variants. Based on the VISION trial, we could consider lutetium PSMA if the lesions were seen on PSMA PET-CT, or the older trial from Alsimca, we can consider radium-223 because this patient could not tolerate docetaxel chemotherapy. That was not a great option. Okay. Now, hypothetically, what if the tumor tissue testing shows this? ATM, which is considered deleterious with allele frequency of 14.2%. So I show this as an example so that we can actually together try to interpret whether these are pathological, whether we can use this or not. So if this was shown through another vendor to be ATM positive, what will we do? Well, in this situation, based on the profound cohort A, because he's a patient who failed ADT plus novel hormonal agent, he fits into the profound cohort. We could consider PARP inhibitor use. And of course, because it's a positive result, as we discussed before in Singapore, our protocol is to consider post-test counseling, genetic counseling, and consider germline testing, also in consideration because he has a family history. Now, so what happens if this test shows this result? Now, hypothetically, just now ATM, we will consider PAPI, even though I know the earlier speaker mentioned that ATM may not be as good response compared to BRCA1 and 2, which is generally possibly true, but still based on the profound indication, FDA is still allowed to, we can still use PARP inhibitors for ATM positive. Now, what about BRCA2? Now, this is interesting because this is BRCA2 of a variant of uncertain significance. And it's written here, no pathological mutation. The question, and this patient, let's say, was subjected to germline blood testing, which did show the same variant of uncertain significance in BRCA2. Now, the question is this likely to be pathogenic given this personal and family history? Is it likely to be pathogenic since it's seen in both tumor, somatic, and germline testing? And does this result in support? Does this result support the patient treated with PAPI? The answer is no for all three because BUS is uninformative and not actionable. So when we talk about variant of insignificance, this is something that I'd like to highlight. In patients, when they have interpreting genetic tests, when it's likely or definitely pathological, this is informative, actionable, they can use PARP inhibitors. But if there's no mutations, of course, it's not actionable because you cannot use PARP inhibitors. But when the result comes back is what we call variant of uncertain or indeterminate insignificance, this is uninformative, not actionable, and it really depends on the number of genes tested. They range from 5 to about 20%. So please note that even if you see a BRCA1, BRCA2, but it says VUS, this is not indicated for PARP inhibitors. Now, finally, this is what actually the patient had. This was my patient who did have BRCA2 and heterogeneous and was classified as a pathological variant. So the question is this pathogenic? Does this result support the treat with PARP inhibitors? And what is the likelihood that this BRCA2 mutation is germline and inheritable? The answer is yes, this is pathological. The answer is it does support the use of PARP inhibitors. And finally, yes, it's likely to be inheritable in more than 70%. So finally, I just want to show that this patient was started on PARP inhibitors and the PSA did respond. The HB remained stable. He was referred to genetic clinic for counseling and germline testing. So ladies and gentlemen, I end my talk with some take-home messages. Molecular testing in prostate cancer is clinically important for prognostic and risk assessment purposes and guide treatment decisions. The HR mutation testing is needed to identify mCRPC patients eligible for PARP inhibitor monotherapy. The combination therapy with novel hormonal agents are now optioned as first-line mCRPC patients. Archival tissue biopsies of primary samples can often be used for HR mutation testing, and there are a number of practical sampling characteristics and tissue yield DNA that should be borne in mind and optimized. And as urologists, I would advocate that we consider this testing in mind to guide initial and subsequent biopsy strategies to perhaps do more course, and alternative testing strategies could be considered in selected patients. So with that, I thank you very much for your kind attention.
Thank you very much, Professor Edmund Cheong. Your presentation was truly insightful and engaging, and the visual you used were spot on in enhancing our understanding. Thank you very much.
Thank you.
Let's proceed to the third speaker, Dr. Fauriski from Medan. Please, Dr. Fauriski, time is yours.
Thank you, Dr. Ferry, for your kind introduction. Good morning, all colleagues and seniors. I will try to share my screen first. I'm sorry. Thank you. Is my slides already seen in your screen? I hope so.
Yeah,
Uh,
clear.
Thank you, Dr. Ferry. I would like to see the perspective for a PARP inhibitor as the precision therapeutics targeting in MCRPC. And as disclaimer, this one is even sponsored by J&J, but we still talk about the scientific reasons. And as we know that the goal of treatment in one MCRPC is to delay metastatic progress and prolong survival, and also like a delay further progression and the onset of severe symptoms, maintain health-related quality of life, and prolong survival. And compared to other treatment regimens, current therapeutic have been shown to improve survival and delay progression, but there still remains poor despite the best treatment currently available. And also there's high unmet medical needs in first-line metastatic castration-resistant prostate cancer, and also in emerging treatments, including combination therapies and novel agents that target various oncogenic pathways, including PARP inhibitor, which use DNA repair defects as a therapeutic targets already explored everywhere right now. And if we see as epidemiologic, prostate cancer is the fourth most common cancer in the world, with approximately 1.2% to 2.9% in all patients with prostate cancers. And the final stage of the disease is metastatic castration-resistant prostate cancer. With the HRR positive of all patients with MCRPC have a 25% of mutation in homologous recombination repair genes. Also, and among patients with HRR positive in MCRPC, the BRCA1 and 2 mutation are estimated to account for approximately half of the HRR mutation, and 1/3 being germline mutation. So we know that the number of cases in 2000 and in Indonesia in 2018 and 2020 in prostate cancers is 7.1%, and In 2020, is it 7.4%, and prostate cancers in 2008 is 7.3% among all other cancers. Right now is with the number of death is 3.8% along all of the cancers. What is the clinical burden of HRR and BRCA alteration? We know that HRR positive prostate cancer is usually more aggressive and associated with poorer in clinical outcomes and worse prognosis than prostate cancer. Without HRR mutation and with HR positive in MCRPC, often left with a poor prognosis even when receiving active treatment such NHTs or chemotherapy, as indicated by reduced PFS and overall survival in patients with DNA repair mutation receiving abiraterone acetate plus prednisolone or enzalutamide or chemotherapy. As long as patient with germline mutation in BRCA1 and 2 significantly more likely to present with a Gleason score more than 8. Is it advanced disease with tumor stage T3 or T4 with a nodal involvement and distal metastasis as diagnosis compared with non-carriers? Patients with MCRPC with somatic BRCA2 mutation have a median overall survival just 14 months, and BRCA2 is associated with significantly increased risk of death compared with patients without BRCA2 mutation. So there's a lot of, as we know that HR mutation, we know that so many genes involved in the HR mutation, like the famous is BRCA1 and BRCA2, also ATM. And if these changes in genes give the clinical outcomes with aggressive tumors, early onset of disease, higher recurrence, and poor prognosis in prostate cancer disease. Also, an HRR germline mutation is associated with increased risk of developing prostate cancer. So we know that germline pathogenic variants in HRR genes are associated with increased risk of developing prostate cancer, with a variant in BRCA2 are associated 2 until 6-fold increased risk of prostate cancer in lifetime risk of developing prostate cancer. As we know that for increase in BRCA1, in BRCA2 it is so 6-fold times compared to the others, and also in HRR germline mutation, BRCA2 also 20 until 60% developing of prostate cancer. So what is we see the PARP inhibitor in DNA repair, that we know that PARP a 17 member of family of enzyme involved in polyadipyribosylation with the post-translational modification of proteins to catalyze the DNA-dependent polymerization of ADP ribosyl units from an AD-positive subset of PARP. So if we see that the PARP will be healing the process in the helical and repair the homologous recombinant, and will be in normal cell, will the DNA repair, or in BRCA mutated cell, which means it will be improve the cells death in prostate cancers. Now we see the landscape of the prostate cancer treatment. We know that prostate cancer is localized or locally advanced, treated with local therapy, and as the time will come with a biochemical recurrence, and will be the progressive with metastatic castrate-sensitive prostate cancer. We follow with the ADT, and in the end, it will become the MCRPC. When we have so many treatment, but the MCRPC will become the poor prognosis and will be leading to the cause of death of so many prostate cancers. Right now, we have so many choice of PARP inhibitors like niraparib, and the first one is olaparib. In the magnitude studies, niraparib, and in the proper studies, olaparib, and now there's a study with the talazoparib, which will be repaired on all of the component of genes here, ATM, BRCA1, BRCA2, also, but some of these PARP inhibitor selective in other genes. So yeah, maybe we see that the more involvement in prostate cancers, BRCA1 and BRCA2, the third agents like niraparib, olaparib, and talazoparib, all affecting of the ATM, BRCA1, and BRCA2. And we see as the AAU guideline, MCRPC 2023, that we see that in the novel agent with polymerase inhibitors to treated MCRPC patient with relevant DNA repair gene mutation. So we have to choose it very carefully, and also over LU PSMA 617 to treated MCRPC patient with one or more metastatic lesion with highly expressing PSMA, actually uptake the liver or the diagnostics radio level in PSMA PET scan. See in the 2022 that in the AU guidelines, we should offer MCRPC patient with somatic or germline molecular testing, as well as testing for mismatch repair and deficiency for microsatellite instability with a strength rating is wrong. And in the ESMO, in 2020, germline testing for BRCA2 and other DDR genes associated with cancer predisposition syndromes is recommended in patients with family history of cancer and should be considered in all patients with metastatic prostate cancer with level 3B, and considered tumor testing for HRR genes and mismatch repair defects with level 2B. And in NCCN in 2022, regarding the tumor testing recommended in patients with metastatic prostate cancer and can be considered in patients with regional prostate cancer. And for HRM, we recommended for patients with prostate cancer with a high risk, very high risk, regional or metastatic disease in familial history or high risk germline mutation. Still in getting the treatment, we should offer the PARP inhibitors to treated MCRPC patient with relevant DNA repair gene mutation. And in the ESMO, olaparib is considered after novel hormonal agents for patient with MCRPC with alteration in BRCA1 and BRCA2. In NCCN, they treat with olaparib for systemic therapy for MCRPC with HRR positive, including BRCA metastatic treatment option, also after given the chemotherapy docetaxel. See, this is from the NCCN, which in the clinical prostate, because we know that as clinician, we perform a physical examination, also with digital rectal examination. We collect the data of the PSA and calculate everything, also do the biopsies, and we give the risk stratification regarding the cancers. And also we need to know the high risk germline mutation and obtain family history. Also in regional prostate cancers, locally advanced or metastatic prostate cancers, we should also obtain family history, and we should see all the initial risks, also see the familial history. But in 2022, germline testing in men with metastatic prostate cancer is still a weak ratio, but also we should see as a clinician to see is it profitable to the patient to the germline testing, maybe because of the high risk from the familial history. And from this study, clinical significance of BRCA mutation, there is currently no evidence of differences in response to PARP inhibitors between patients in BRCA1 and BRCA2 germline mutation induced with somatic mutation. So BRCA1 and 2 must be determined using a recognized and validated method. Is it enigma, YARCH, or ATCC criteria? And the type of BRCA1 and 2 variant should be systematically described in the final report, including references and correlation with clinical risks. And the tissue testing should be carried out at a time when in a specific setting where there is indication for partial treatment, like if we consider to give the PARP therapy. And also it is recommended that BRCA1 and 2 somatic testing should be included in the diagnostic and therapeutic care of patients with advanced or metastatic disease with age below 55 years at the time and diagnosis, and patient with documented genetic risk. Also, when indicated, BRCA1 and 2 testing should be requested, which is with a multidisciplinary team or a clinician with documented experience of prostate cancer management, even without evaluation of a clinical geneticist, which and also we see that this paper of the association between BRCA2 alteration and intraductal and cribriform histology in prostate cancer, they have a total 174 primary prostate tumors and referring with 58 mutant cases and 116 non-carriers. The high prevalence of B-allelic BRCA alteration, it means BRCAness, describe up to 70% of the primary prostate tumors arising in germline BRCA mutation may have act as a confounding factors in private studies and report between intraductals and cribriform BRCA2 association, and no association between the BRCA mutation and ADC or cribriform histologies. With B-allelic BRCA2 loss in primary prostate tumors was significantly associated with both variant morphologies independently of other clinical factors. So, what can detection of germline HRR pathogenic variants mean for patient? As meant for the diagnosis, we should see that germline pathogenic variants in the prostate cancer susceptibility gains confer a substantial increase the risk for developing of prostate cancer, and germline analysis may be extended to family members to identify the asymptomatic carriers of pathogenic variants. And in the management of the disease, the germline testing, we can identify variants that we can see the high risk of the metastatic disease, also that we can conferring greater tumor sensitivity and overall survival benefit by given the targeted therapeutic like PARP inhibitor. So there's a rationale for combining PARP inhibitors with androgen receptor signal inhibitor with the twin rational therapy to combination between the PARP that PARP inhibitor potential efficacy may induce the pharmacological BRCAness. So there's a previous speaker said that the BRCAness, something mentioned before that the BRCAness given with the androgen receptor signaling inhibitor, so it will be give the sensitizer to the gene to give the patient the benefit survival for given the combination therapies. And also with the combination of PARP inhibition and androgen receptor signal inhibitor, with leverage pharmacological induced BRCAness to cause tumor cell death and may provide benefit with the androgen signaling pathway regulates the repair gain expression, which may in part contribute to its growth promoting activity. This is the head map of HR regulator with the androgen activity is induced in response to double-strand DNA damage, generating reactive oxygen species and free radicals, and increasing expression of androgen receptor target genes, including several DNA repair gains and PARP inhibitor to resolve double-strand lesion. And with the use of PARP inhibitors, the androgen signaling pathway regulates the DNA repair gene expression, which may in part contribute to its growth promoting activity. We know that a significant correlation exists between the R transcription output and the enriched DNA repair genes, with the significance connection between supporting a link between R signaling and DNA repair, with the restoration of the R signaling pathway in prostate cancer via androgen receptor amplification and mutation of the R gene sensitized tumor cells to growth stimulating effect of the androgen receptor and drives prostate cancer into a castration-resistant state. So, with the combination of the PARP inhibitor with androgen signal inhibition, it will be sensitized prostate cancer to PARP inhibitors. There's a study here, clinical evidence of niraparib plus abiraterone as an inducer of pharmacologic BRCA that show that the greater tumor shrinkage and longer survival with the combination between these agents. And also it will clinical study in of multiple HR gains causing HR deficiency is pharmacologic brokenness and sensitization to the combination of enzalutamide and olaparib in castration-resistant prostate cancer, with the analysis of drug treated in this table treated with LNCP cells using quantity PCR based HR assays shows that enzalutamide ola reduce HR efficiency, and their combination further reduce HR combination efficiency. See, with the combination use of PARP inhibitors with artisanal inhibitor leverage pharmacological induced brokenness to cause tumor cell death and may provide clinical benefit. In the study with the olaparib plus abiraterone acetate plus prednisone, it's demonstrated superior in RPFS in comparison to abiraterone acetate plus prednisone alone, regardless of the condition of BRCA. And if we know that the study between two big study, it's magnitude and propel. Magnitude using the niraparib and propel use the olaparib, and but as there's no significant changes in quality of life in both study of the patient in these two study. Okay, and I now try to conclude that HRR germline mutation are associated with increased risk of developing prostate cancer, and HR positive prostate cancer is usually more aggressive and associated with poorer clinical outcomes and worse prognosis than prostate cancer cases without HR mutation. We need more guidance to maximizing the treatment benefits, and earlier germline diagnostic will support treatment and MCRPC pace, and earlier therapy will impact on treatment choice in MCRPC pace. Also, the use of PARP inhibitors with the androgen receptor signaling inhibitors leverage pharmacological induced BRCA to cause tumor cell death and may provide clinical benefit. Like I said before, that it will sensitize prostate cancer to PARP inhibitors, and the androgen signaling pathway regulates then a repair gene expression, which may in part contribute to its growth promoting activity. I think that's all on my presentation. I will give back to the chairman. Thank you.
Thank you, Dr. Fauriski, for sharing your presentation. Now we entering the discussion session. Any question from the participants? Please write down your question in the question box. Okay, this is a first question from Dr. Farhan Suseno. For monitoring treatment response in patient with MCRPC before and after radiotherapy, which method is the best, MRI on or bone scan? What is a gold standard assay for treatment response in MCRPC? Okay, please maybe for your from Dr. Professor Edmund and Dr. Foriski, from your experience, please.
Would Dr. Foriski like to respond first?
Okay, Dr. Foriski.
Thank you, Prof. I would say that the question is before and after radiotherapy, right? I will prefer that if we have a facility of bone scan, but if the patient have a systemic condition for like a bone lesion, bone scan is very useful to give the guidance to the radiotherapist for given the radiotherapy. But for early diagnostic before starting the therapy, MRI have a usefulness, especially in the locally disease of the prostate cancer. That's in my field of experience.
Okay, how about you, Professor Chong?
Yeah, so I think if I read the question correctly, it was asking for patients who have metastatic prostate cancer undergoing radiation to prostate. And what we are referring to is a low volume metastatic disease based on the STAMPEDE protocol, where you give radiation, or rather low dose radiation to prostate. Now, the question is, in my mind, I'm wondering, why do we need to do imaging after radiation? Because normally we will see patients, the aim of radiation to the prostate is really to increase overall survival. And preferentially, we would also have considered treating patients with novel hormonal agent at the same time. And that's what's commonly being done in Singapore. So I think the usual monitoring of the PSA levels in terms of response would be good. And there are some considerations to repeat imaging at some point. And I would advocate conventional imaging, for example, CT bone scan, CT's thorax, abdomen, pelvis plus bone scan. But I don't think there's a need to specifically image the prostate to see response to the prostate, because the aim is overall survival. So I think most of the time when we do imaging for metastatic prostate cancer, we really wait and see if the PSA is starting to rise again. Yes, that's the point. We will redo the entire imaging of both the axial skeleton of the bone scan plus the axial images like CT. So we don't routinely do scans after radiation just to assess the response or the size of the prostate.
How about using the testosterone and also the PET scan is regularly used in Singapore?
Yeah, that's a very good question. So I think increasingly there's been increasing use of PSMA PET CT for staging and also for monitoring. I think in Singapore, my personal recommendation and practice is I still continue to do conventional imaging as a primary default. The reason is because, number one, PSMA PET CT is expensive compared to conventional imaging. Number two, all the current trials in metastatic prostate cancer are all done based on criteria, for example, charted criteria or volume disease, are all based on conventional imaging. We don't really know what it means when you have a PSMA PET diagnosing, for example, a high volume disease. Does it, if you do a conventional imaging, it shows low volume. Do you treat as low volume? Do you treat as high volume? So that is still uncertain at this point, because the data for survival outcome really comes with conventional imaging. So the only time we consider doing PSMA PET is when there's some discrepancy, like we're not sure whether on conventional imaging this is metastases or not. Yes, we use a PSMA PET to decide whether this is likely to be. And of course, sometimes if you're very concerned that there's a discrepancy, for example, in low volume disease that you see in conventional imaging, but the PSA is extremely high, the patient is not well, then you wonder whether you're missing something. So I think in those situations, we do selective PSMA, PET-CT rather than than to do it for everybody.
Okay. How long do you take the imaging after the radiotherapy ended? Dr. Faurisky, how long after the radiotherapy treatment you do the imaging?
I will do the imaging, but after I evaluate the PSA after the radiotherapy, Dr. Ferry. So usually after the therapy, I will start to measure the clinical outcomes, also with the PSA levels, usually 1 month after the radiotherapy and also in 3 months after the radiotherapy. And also in sequential, we see the progression of clinical outcomes within the patients.
Okay. How about you, Professor Chiao?
Yeah, so our radiation oncologists sometimes would consider doing MRI later on, but usually we don't do so early. Most of the time they will wait for at least more than 2 months, but usually at least 3 months or beyond to consider any form of repeat imaging. The reason is because they want to see that they want the effect of the radiation to respond. But however, having said that, it really depends on the intent of the imaging, because I think really in metastatic disease, we understand that the intent is more for overall survival.
Yeah. Okay. Any question from the floor, from the audience? Okay, this is Dr. Ananda for Prof. Edmund Siong and Dr. Faurisky. What is the benefit PARP inhibitor in HRR differentiated tumor, and what's condition PARP inhibitor not accumulated in HRR this patient's tumor? Okay.
It's a very good question. Yeah.
Yeah. Please.
Yeah, this depends on the condition of the clinical. I said that if there's we can give the proof to BRCA2 or BRCA1's changes, like Professor Edmund do in the Singapore. If we'll give a benefit in the progression state of the disease, but all of we in Indonesia, we have like a facility to diagnosis with the germline testing here, and also some of my patient I testing, but all the result is there's no also it from plasma, but all the result is there's no changes in the BRCA1 and BRCA2, and yeah, I said that PARP inhibitors will give clinical benefit if the patient have proven that there's some mutation in the genetic testing, but also because of the therapy is in the Indonesia, it's out from the patient's own pocket to buy the therapy. It's relatively expensive in Indonesia. So yeah, we must be very selective to give this therapy, the PARP inhibitors to the patient, and must be very careful and very selective. If there's we predict, then we discuss with the patient, it's no given any clinical benefit, I will not recommend to give the PARP and therapies to the patient.
Okay.
Yeah. I completely agree. I think it really depends on firstly whether you think the initial testing was adequate. As we discussed, there are a lot of pitfalls to somatic testing, and there are options of rebiopsy or testing blood with ctDNA or germline testing to see whether it's negative or positive. If it's truly negative, I think there's no role if the patient had already received novel hormonal agents. But in the current issue, it is only ADT alone. We are aware that there's the 3 trials with Propel, Calapro-2, and Magnitude. But even Magnitude does require positive testing. So I think I'm not quite somebody who would advocate that Propel, because I don't think that we should be giving unselected patients at this point without OS benefit. So I really think that if it's truly negative, I would consider other options.
Okay. Any question for Dr. Didik? Maybe from the floor? Okay. Yeah. Okay. Please, Dr. Didik, about the current situation of HRR or genetic testing in your institution. How many CRPC go to HR testing? Okay.
Okay,
Please.
thank you, Dr. Satria, for the question. Yeah, honestly, in our institution, I myself, we never received request for the BRCA testing. Yeah, even in our institution, we have NGS as platform, but so far we never accept the request for the BRCA testing. Up to now, most of the patients just send the request form to our laboratory to cut several slides from the FFPE. Then the patient would send to the perhaps one of the laboratory that provide the BRCA test in Indonesia or in maybe abroad. Yeah. So basically, yeah, I can say that we never have experience to check the BRCA, but if from the future, if the clinician would like to, I mean the number of the requests to check the BRCA rise, yeah, we are happy to start the BRCA test in our institution. Basically, we have the platform, yeah, NGS. But yeah, we thought that it has highly cost, yeah. So yeah, perhaps we have make a collaboration with some pharmacists to cover the test cost, yeah. Maybe that's my opinion and perspective.
Okay. Okay. By the way, if you have a patient with suspicious of BRCA mutation, what step do pathologists take to confirm and validate this genetic alteration? Is there any another step to confirm this mutation?
Yeah, basically the determination of whether this is mutation or not based on the NGS test after the take out the result. So the expert, the bioinformatics, will analyze it. So it's not the pathology field, yeah, I think. Pathologist field. So so the pathologist field is start from the diagnosis, yeah, then provide the good material or good specimen from the FFPE to perhaps to send to the other laboratory that provide BRCA test. But yeah, as I mentioned previously, the conclusion whether this is BRCA pathogenic or maybe just the variation is from the bioinformatics, yeah, from the pathologist, yeah.
Okay. Okay. Any question again, Dr. Linggar, from the audience? Oh, yeah. This is for Dr. Didik.
Somatic testing.
Yeah, somatic testing atau block.
Yeah. In bahasa or in English, yeah.
Maybe in English, maybe because we have the Professor John.
Yeah. Using the fresh tissue and paraffin block or FFPE, for the somatic testing. Yeah. As for the quality of DNA, as we know that fresh tissue will give the high amount of the DNA compared to rather than the FFPE. But as I mentioned in our presentation, but to get the fresh tissue, some usually clinician has a limitation, due to perhaps the condition of the patient, or maybe clinician will know very well, But in my opinion, FFPE still will give the good result, So and also in my presentation that to check the somatic mutation, better we use the tissue, where tissue either from the fresh tissue or from FFPE or paraffin block, So which one the better depend on the condition, If the patient or the condition is suitable to get the rebiopsy, I think fresh tissue is better. But we have to be careful. If you take the fresh tissue, you should confirm or convince that the tissue that you take from the patient is contain the tumor. Because from the fresh tissue, we don't check firstly with the microscope, So like a blind tissue sent to the pathology or lab that provide the BRCA test, That's the point, We have to be careful, Sometimes just blind the biopsy, then no tumor inside. So this is the we have to be careful about this matter, Dan bagaimana pendapat manajemen pertama kali dari biopsi langsung diperiksa somatik? Saya kurang paham pertanyaannya. Bagaimana banyak bila kita mengambil spesimen pertama kali baik dari biopsi atau langsung diperiksa somatik atau if you have the tissue, better we check the somatic, Any kind of tissue from the biopsy procedure or prostatectomy, Once after we get the tissue, better we check the somatic mutation, because by the somatic mutation we can capture both germline and somatic mutation. Maybe that's all my explanation. Maybe other speakers would like to give additional answer.
Maybe Dr. Fauriski?
Yes, from this question, I would like
question number 2, I think.
Yes, because to Dr. Didi, there is possible changes for the mutation after the radical prostatectomy that the patient given like maybe ADT or something? Is it possible that after the radical prostatectomy, the patient before when the radical prostatectomy was did, there's no germline mutation, but after some of time, maybe within the therapies given to the patient, is it possible that there will be mutation changes in the somatic? Thank you.
You mean that is there possibility the alteration of BRCA mutation status before therapy and after therapy?
Yes, I will have to say that.
Very possible, because the mutation is very heterogeneity. When the first we check from the first tissue, there is no clone that bring the mutation, but after the therapy or after by the time, then the proliferation cell will contain the clone of the mutation. So it's very possible due to the heterogeneity of the tumor.
Okay.
Yeah, I think so too, because I think we have to differentiate between germline and somatic mutation. Now, germline will always be there. So whether you do a prostatectomy, you give ADT, it will always be there because it's germline, it's inheritable. What we're talking about this is somatic mutation. So you can see that even after treatment with ADT or various treatments, the cancer cells can mutate and develop mutation along the DNA repair pathway with HR mutation. That's why you see in one of my slides, when you see the pictured paper, in MHSPC, it was about 12%, but in MCRPC, it was 25%, almost double. So you can see that with additional treatment, patients can acquire somatic mutations.
Yeah.
Thank you.
Okay. Any question from the audience? Okay. For Professor Edmund and Dr. Faurisky, what is the limitation in development of PARP as the treatment of MCRPC?
Would Dr. Faurisky want to start first?
Yeah, please.
Okay, I think I try to answer the limitation. The development of PARP as the treatment. I think it is about the mutation that we found. Is it truly there's proven that there's a mutation or not? If there's no mutation at all, why we given the PARP as a treatment? It will be not cost effective for the patient. I think so.
Yeah.
Thank you.
Yeah, agree. I think PARP inhibitor has some limitations. Firstly, as you already heard in all our slides in our discussion, there are some it's not easy to do the testing, and the HR mutation testing does come with certain criteria of have adequate good quality DNA before you can detect, and even then the positivity rate is about 20% of the test. And so this is one limitation, that not everybody that you test will be positive. The second limitation with PARP-I, of course, is got to do with the fact that it's expensive. It does come with certain costs. And thirdly, of course, it really depends on the mutation that you get. So I think it works best in terms of what was mentioned by the earlier speakers, the BRCA-ness, right? The increased BRCA-ness of BRCA1, 2, maybe ATM and B2 maybe will work, are likely to work. But the other minor aberrations, we're not certain whether the data supports it, that it will work or not. So we're not sure, really. So there are some limitations in this treatment. Yes.
Yeah. Okay. Anything else? Question? Again, for Professor Chiang and Faurisky, what is the best diagnostic procedure to be used to monitor a patient progress on a PARP inhibitor? And
I think the follow-up for MCRPC remains the same. We will monitor the PSA response. Unlike radium-223, most of the other treatment, the PSA do respond if you do work for most of the patients. So we routinely follow up with PSA. Of course, you could repeat imaging, but that's really quite variable practice. Some clinicians practice regular imaging, while some wait for changes in PSA or clinical status before you repeat imaging. So I think it doesn't change. But what's important in PARP inhibitors in terms of monitoring is the adverse events. So I think the adverse events, one of the important ones is hematological. You can have anemia as an important adverse event.
Yeah.
So what's important to monitor is really the blood and the clinical status of the patient. You need to check the full blood count, you check the organ functions. I think these are the things that we will monitor while the patient's on PARP inhibitors.
Yeah. Do you think is there any place to do the intermittent treatment for PARP inhibitors?
Wow, that's a very high-level question. That's difficult. Honestly, I don't know. The trials have not studied it that way, and I understand intermittent may help in terms of morbidity, low because of the issue of anemia, but I really don't know. I don't think the trials have studied it that way.
Yeah. And how long do you suggest to give the PARP inhibitors? Until the 1 year or 2 years, as such as the ARTA?
Yeah, so I think PARP inhibitors, based on the PROFOUND study, the average time that patients were on it were somewhere ranging from 8 months to over a year in terms of the OS benefit. So I think that would probably be around there. But of course, if you're using as a combination, at the start when patients only had ADT and you are giving, for example, PARP plus enzalutamide or abiraterone, I think it would be much longer. Similar to what we see in novel hormonal agents, they could be well on this treatment for at least maybe 2 years or 3 years even, or even longer. Yeah.
Okay. Any question? Still there? Yeah.
Okay, that's another interesting question.
Yes. It's not a trial, I think.
Yeah, I think at this point, there is no clear use of radiation. I assume that you're talking about radiation to the prostate. I don't think there's any clear indication to give radiation to the prostate in MCRPC if we're using PARP-I at MCRPC. However, if basically you're talking about patients who are indication of combination, for example, PARP-I plus novel hormonal agents, after you fail only ADT for low volume disease, maybe there's some role, but this based on STAMPEDE, but STAMPEDE did not study combination with other agents, so it's hypothetical. So we don't know. Maybe there's some help, but we actually don't know.
Yeah. Okay. Any questions still from the floor? Okay. If no question, I think
there's one question again, Dr.
Oh,
Ferry.
yeah, please.
But yeah. I'm sorry.
Okay. Can PARP inhibitor use for all type? What kind of
Another tough question. Now, I think when you say all types, you're referring to the combination therapy trials like PROPEL, Magnitude, and ColorPro-2. I think we have to be very careful here because in PROPEL, they had all comers. They advocate everybody in PROPEL, right? It's unselected. Now, of course, we know that that has been approved by the Europeans for this combination use, but I think that the issue is at this point is only RPFS benefit. We don't have overall survival benefit. We're not certain whether this combination is viable because in Magnitude, certainly it was patients who had HR mutation positive who really benefited. And certainly in PROFOUND, and that's what we call precision medicine. But somehow I find it very difficult to reconcile that when we are doing precision medicine, we take a step back and say, everybody may benefit. I'm not so sure yet at this point. Yeah. I don't know what's the opinion from the rest. Dr. Roski, what do you think?
Maybe Risky? Any
suggest
any?
Yeah, I think about the use of PARP and limitation, I think we should know that Dr. Ferry, in Indonesia, we should very carefully selective the patient because of the cost and calculate between the cost and the benefit for the patient because we know that this relatively expensive.
Yeah.
And also that we know that from PROPEL study and Magnitude study, it's a two big study that differentiate within the PARP inhibitor being used. In the PROPEL study, used the olaparib with the abiraterone and the niraparib. They're very selective, but use niraparib in the Magnitude study. So begin the therapy of the PARP, we should very selective and very careful, and you should consent the patient very carefully because of the result will be we only can predict, but the result will the time will tell us in the meantime. So yeah, the limitation maybe with in Indonesia, it's still out of pocket for most patients because we know that it's relatively expensive. And also, Dr. Ferry, we have nice news from Dr. Didik that they have the next gen sequencing in in Jogja, so we can try to tell the patient that we can send some tissues maybe to Dr. Didik to be examined that if there is some mutation or not. And from the testing mutation, we could conclude that the PARP have a effect benefit for the patients. Thank you, Dr. Ferry.
Okay. Due to the time is over, if no question more, I will summarize this webinar. The summary highlights the evolving landscape of prostate cancer treatment, specifically addressing the significance of BRCA mutation in mCRPC and the therapeutic utilization of PARP in this context. In the advanced stage of metastatic mCRPC, patients with BRCA mutation have been shown to exhibit aggressive disease progression and poorer outcomes. And PARP inhibitor have emerged as a promising class of drugs in the treatment of mCRPC with a BRCA mutation. And we know the clinical trial have demonstrated the efficacy of PARP inhibitor in treating mCRPC with BRCA mutation. In conclusion, the understanding of the role of BRCA mutation in mCRPC and the development of PARP inhibitor have reshaped the treatment landscape for this aggressive form of the prostate cancer. Thank you very much. I return to the MC.
Okay. Thank you so much. We would like to send our thank you, our gratitude to our speaker, our event chairman, Dr. Ferry Safriadi, specialist urology consultant. Thank you also for the summarize our session that in line with our objectives, that to introduce and raise the awareness of the importance of BRCA testing prior to the next precision treatment that we can choose as the treatment option in mCRPC next. Then we would like also to say thank you for Dr. Didik Setio Herianto, PhD Specialist Pathologist Anatomy, Associate Professor Edmund Chiong, and also Dr. Foriski Febrian Krapiska, Specialist Urolog Consultant, for all the session that very insightful to give us your insight and like inputs for us about treatment option and testing BRCA. So before we close the session, I would like to remind you, our participants, our professor, doctors that already attend from the beginning until the end of the session, to fill the link on the chat box or in the scan barcode on your screen to put your feedback, and also fill the post test to get certificate SKP ID after the session from PPIAUI. The certificate will be sent through your email. So we hope you to put your complete name and complete email on the section, on the link. So the last of the list, before we close the session, we would like to kindly open your camera if possible, and also for our event chairman, Dr. Ferry, and also our speaker to open your camera to take some photos for our beautiful session today. Maybe Mbak Nia from our team, medical team, could you help us to take some photos?
Yes, Mbak. Could you please stop share for a moment, Mbak?
Okay.
Okay.
Sir, please smile for our session. Thank you so much. Mbak Nia, please
Yeah.
guide. Yeah.
Okay. Please smile. 1, 2, 3. Once again. Okay. I think. Oh, okay. Okay, please smile. 1, 2, 3. Okay. Thank you.
Sudah? Okay, thank you so much for all our beautiful session. Very awesome, and we hope this session can give a lot of benefit to our participants today. Thank you so much. We would like to close this session from Johnson & Johnson Indonesia to see you on the next session. Assalamualaikum warahmatullahi wabarakatuh. Selamat siang.
Thank you very
Thank
much.
you.
Thank you, Professor Chiong.
Thank you all.